Hey everybody, and welcome back to another episode here at Whiteboard Medicine. We appreciate you checking it out. Hope everyone's having a good day. We're just coming off a week of rounding in the medical intensive care unit. Very pertinent for the episode today, the CAM ICU confusion assessment method for the ICU. Well, if we could speak better, that'd probably be good. So we are going to be talking about the CAM ICU assessment today. This is a really important tool, one we probably underutilize in our intubated patients, and it's a method to assess for a delirium in our mechanically ventilated patients. If I could borrow a quick 60 seconds of your time, I wanted to introduce you to a community we're really excited about building, and that is our Patreon community. In this community, you will get access to high-yield medical education posts, ad-free videos, study guides, practice questions, mini courses, book chapters, and much more. You will see that by joining this community, you will get access to the PDFs, the study guides for every single YouTube video. Here's an example of one of those right now. In addition to that, you will get access to mini courses. In these courses, we will have videos, study guides, practice questions, bedside tips and tricks, and 30 practice questions at the end to test your knowledge. In addition to that, we have collections on every major emergency critical care topic that contains videos, medical education posts, practice questions, study guides, all categorized. And lastly, we have book chapters. These book chapters are high-yield clinical reviews, such as this one on the basics of mechanical ventilation. Beyond that, we have ad-free videos, we have practice questions, and we are constantly innovating and integrating new resources for you all. If you have a passion for emergency critical care medicine like us, consider joining this community today. In it, we hope that you will find all the resources necessary to push your knowledge to the next level and really improve the bedside care of these critically ill patients. By the end of the episode, we hope that you have a full grasp on the CAM ICU tool. We hope that you understand how to use it, how to do it, what it means. We'll talk a little bit about delirium too. And by fully grasping that, we hope we can push our care of these patients kind of one rung higher, right? Identifying delirium rather than trying to, over-sedated or under-sedated or what have you is really important, because the approach to delirium is much different than the approach to pain or anxiety or agitation or what have you. So no further ado, let's dive into CAM ICU. So what is CAM ICU? Well, CAM ICU is a validated bedside tool used to screen for delirium. Okay, we want to tease that out a little bit more. So it's a validated bedside tool. So validated means that it's been studied, right? This isn't something someone just willy-nilly made up, right? It's been studied and has been shown to be a tool that does what we think it does, which is screening for delirium. It's a bedside tool. This isn't something you could do from the computer, just looking at labs. You got to go to the bedside and actually do this with the patient. And it's a tool. This is not the end-all be-all. This is an adjunct to the larger clinical picture, right? You shouldn't just use this tool and use it in isolation and say yes or no, right? This should be an adjunct to what else is going on with the patient. It should be a data point within the larger specter of their clinical progression. And it's best used in intubated and mechanically ventilated patients. Some people do use it in nonverbal patients. We don't have as much experience with that, but intubated and mechanically ventilated patients, certainly appropriate to use it there. So the key idea here is delirium is acute brain dysfunction, and it's very common in critical illness. And we care about delirium because it's associated with a lot of really tough things. It's associated with longer ICU length of stay, longer time on the ventilator, higher mortality risk, long-term cognitive impairment, increased distress for patients and families. And the reality here is we don't have a good solution for it. Right? There's been lots of trials on things, and we don't have a great way to fix it. So CAM ICU helps you detect delirium reliably instead of just guessing. And if we can detect it, then we can start to approach it with some of the things we know can potentially be helpful. So what exactly is it? We've talked about delirium contributing to worse outcomes. What is delirium? Well, delirium is this acute onset of fluctuating mental status. It might have some inattention, disorganized thinking, all the way to altered level of consciousness. And it can be either hyperactive, you're agitated, agitated, you're pulling at lines, you're restless, or hypoactive, which we miss more often, right? You're quiet, you're withdrawn, you're sleepy, you're not engaging. So it can be either, right? There are these two different phenotypes of delirium, hypoactive and hyperactive. Some people talk about a mixed version, where it goes from hyperactive to hypo. Maybe that's true. Maybe that's more related to some of the medications we're giving, unclear. But there's certainly these two different phenotypes. Okay, so your patient who's agitated, pulling at lines, restless, are they in pain? Are they anxious? Or are they delirious? The treatment of those three things is very different, right? So this is a super important foundational concept that we need to be better at diagnosing. Q, the CAM ICU score. So when can you use CAM ICU? Well, you generally need the patient to at least be somewhat arousable. We've talked on this channel about RASS scoring for anxiety and agitation. If this is something you're interested in, just search Whiteboard Medicine RASS, it'll pop up. And the RASS score tells you kind of the level of anxiety, agitation, arousability, call it what you will. But for the CAM ICU tool to be used, the RASS has to be greater than -3. And that's confusing because there's greater and negative in the same sentence. So it has to be -3, -2, -1, or 0, 1, 2, 3, 4, right? It cannot be less than -3, so the patient cannot be a RASS of -4 or -5. And remember that RASS of -4 is that they're only arousable to physical stimuli. RASS of -5 is that they're not even arousable to physical stimuli. So you can't use this tool in patients that are that not arousable. Whereas RASS of -1 is with a verbal stimuli, you make eye contact for 10 seconds or more. RASS of -2 is with verbal stimuli, you make eye contact but for less than 10 seconds. And for RASS of -3 is with verbal stimuli, you open your eyes but you don't make eye contact. So we can do the CAM ICU with, arousability of -3 or more arousable. So your workflow when you're doing this is really you should do a RASS first, because if the RASS is more negative than -3, aka they're only arousing with physical stimuli, then you can't even do your CAM ICU score. And you should be thinking about if we are overly sedating them or something else is going on. But let's say that they're more arousable than a RASS of -3, cue the CAM ICU tool. So there's 4 features here. Feature 1 of the CAM ICU tool is, do they have acute onset or fluctuating course? And we'll just say, we don't have any sponsors on the channel, including MD Calc, but we do enjoy MD Calc. And if you look up CAM ICU, this is a website, it's free, you can go on there. They have a lot of, again, this is not, as we say 1 bazillion times, none of this is intended to be acted upon as medical advice. This is all just conceptual and education for those in the healthcare arena, but certainly check out the full disclaimer in the description or the end of the episode. So we don't want you to blindly follow this stuff, but if you go to MD Calc and type in CAM ICU, it'll give you the features that we're starting to talk about, and you can fill them out. A lot of EMRs have ways to do this too, and our awesome ICU nurses probably are much better at this than we are, because we're physicians here. So if any of the ICU nurses watching this episode have tips or tricks or critiques or suggestions, certainly let us know in the comments, share them with the community. We'd love to hear them because you guys are much better at this than we are, I'm sure. So feature 1, acute onset or fluctuating course. Is there a new mental status change from baseline? Does it come and go, fluctuate over the day? These are critical. These are critical parts of the score. You cannot test positive on the CAM ICU score without this being true. So is the patient normal in the morning and confused at night, or vice versa? Do they alternate agitation, somnolence, or more awake or less awake, or more comfortable and less comfortable? So is it fluctuating, and is there a change from baseline? That's feature 1. Feature 2 is inattention. This is the core of delirium, right? You can test this. The classic is like the letters attention test. So ask a patient to squeeze your hand or blink when they hear the letter A, and then give a string of letters that include A, right? If they miss the A's, or they squeeze on the wrong letters, or they're just not participating in general, that suggests inattention. That suggests that delirium is more likely. Okay, so the squeeze letters or blink eyes when they hear the letters A test for inattention. Feature 3 is an altered level of consciousness. So if they're just alert, calm, interactive, comfortable. That means that they probably aren't delirious. Maybe they are, but they probably aren't. Anything other than that, so that would equate to a RASS of 0. Anything other than a RASS of 0 means that they have an altered level of consciousness, okay? And then feature 4 is disorganized thinking. So you can ask some simple questions. Are there fish in the sea? Will a stone float? Does 1 pound weigh more than 2 pounds? Hold up this many fingers. Do the same with the other hand. And see if they have organized thought. If they're unable to do these things, then they are most likely disorganized. And we'll get into, so we're going to do a step-by-step approach, and then we'll get into, how to quote-unquote score the CAM ICU. And it's not really scoring. It's positive or negative, but we'll get into that. But these are the 4 features. So feature 1, as we said, acute onset or fluctuating mental status. Feature 2, they're inattentive. You can consider the squeeze my hand when you hear the letter A test. Feature 3, altered level of consciousness, which means their RASS is not 0. And feature 4 is they're disorganized in their thinking, right? They can't hold up the right number of fingers, blah, blah, blah. Okay, how to interpret the CAM ICU? Well, the CAM ICU is either positive or it is negative. There's not, a CAM score of 3 or a CAM score of 1. And to be positive, you need feature 1. So you need acute onset or fluctuating mental status. And you need feature 2, right? Feature 2 was, we'll scroll back up so you can see it. If you're watching the video, if you're listening to the podcast, we'll narrate it as well. But feature 2 was inattentive. So you need to have feature 1 and feature 2, which means the patient needs to be inattentive, which we talked about the squeeze my hand when you hear the letter A test, and they have to have acute onset or fluctuating altered mental status, okay? And then they need to have either feature 3 or feature 4, right? Feature 4 was they're disorganized, and feature 3 was that their RASS is not 0, right? They're anything other than calm, relaxed, interactive. So the CAM ICU is positive if they have acute onset of altered mental status or fluctuating, and they have inattention, and they have either a RASS of anything other than 0, or, I know this is a lot of words that are confusing, they're disorganized in their thought. Hopefully that makes sense. So step-by-step approach to CAM ICU. So step 0, check the RASS. If the RASS is less negative than -3, aka they're not -4 or -5, then proceed. So that just means if they open their eyes to any degree with verbal stimuli, then you could proceed. Okay, so that's step 0, check the RASS, because you can't even do the CAM ICU tool if the RASS is more negative than -3. Step 1, feature 1. Do they have acute onset of altered mental status? Is their mental status fluctuating? Okay, so look at the chart, talk to the nurse, talk to your colleagues, talk to the patient. If they have acute onset and or fluctuating mental status, move on to feature 2. Do they have inattention? You can do the letter test. Squeeze my hand when you hear the letter A. If they have inattention, then move on to step 3, right? Because if they don't have feature 1, so if they don't have acute onset or fluctuating mental status, then just stop there, because the CAM ICU is going to be negative. If they don't have feature 2, if they don't have inattention, just stop there, because the CAM will be negative. But if they have a RASS of less negative than -3, aka they open their eyes to any degree with verbal stimuli, then move on to feature 2. If they have acute onset and or fluctuating mental status, move on to feature, that's feature 1, move on to feature 2. If they have inattention, move on to feature 3. And once you're past feature 2, right, if they have a RASS that is less negative than -3, if they have acute onset or fluctuating, and if they have inattention, then you're going to be doing both feature 3 and 4, right? Because we talked about how it's now at this point either, right? If you have feature 3 or feature 4, it's still going to be positive. So feature 3 is assess RASS. If the RASS is anything other than 0, calm, cool, collected, then it's going to be positive. If the RASS is 0, move on to feature 4, right? And ask, Simple questions or commands. Lift up this many fingers, do the same thing with the other hand. If that's positive, then it's still CAM ICU positive, okay? Because that suggests they're disorganized. So if we were to do kind of quick memory tools, CAM ICU logic, you need to be a RASS of less negative than -3. You need to be acute onset and or fluctuating, as well as inattentive. And then you either need to be a RASS of anything other than 0, or you need to be disorganized in your thought. So 4, feature summary: acute fluctuating, inattention, altered consciousness, disorganized thinking. Hopefully that was helpful. We're going to dive into 3 practice questions to end this episode. For those of you who have done practice questions with us before, you will know we read the question, read the answers, and go right into the actual answer. So if you need more time to think, just pause the episode. We start with the beginning, then intermediate, then advanced question, and then that'll be the end of the episode. So question number 1, CAM ICU is considered positive when which pattern is present? A, feature 1 and feature 3 only. B, feature 2 and feature 4 only. C, feature 1 and feature 2 plus feature 3 or feature 4. Sorry, lots of the word feature. D, feature 1 and feature 4 only. Correct answer is pause if you need to. C, CAM ICU requires acute change, feature 1. It requires inattention, feature 2, and then either altered consciousness, which is feature 3, or disorganized thinking, which is feature 4. All right, question number 2. A patient is mechanically ventilated with a RASS of -5. What is the best interpretation? A, CAM ICU negative, B, CAM ICU positive, C, delirium confirmed, or D, CAM ICU cannot be assessed due to deep sedation. The RASS is -5. The correct answer is D, right? You need to be a RASS of less negative than -3 or greater than -3. If you're a RASS of -4 or -5, which is means -4, you arouse with physical stimuli, -5, you don't even arouse with physical stimuli, then you cannot even do the CAM ICU test, okay? Question number 3, the last one. Which CAM ICU features the core cognitive deficit most essential for delirium screening? A, acute onset fluctuation, B, inattention, C, disorganized thinking, or D, altered level of consciousness. Correct answer is B. Inattention is central to delirium physiology. It is a required CAM ICU positivity. If you are not inattentive, CAM ICU will be negative. Now, it maybe would be fair to choose A, acute onset or fluctuating mental status, because this is mandatory as well, but it's less part of the pathodrome of delirium, which is why I chose B. But in retrospect, maybe that question could be a little bit better. But nonetheless, y'all are rock stars. Let us know what thoughts, comments, questions you have down below. Check out our other episodes. Hey everybody, and welcome back to another episode here at Whiteboard Medicine. We appreciate you checking it out. Hope everybody is having a good day. We are just finishing a week rounding the medical intensive care unit, where the CPOT score is something that was frequently utilized in our mechanically ventilated patient population. And that's what we're going to be talking about today, the critical care pain observation tool. Hopefully by the end of this episode, whether you're listening to it in podcast form or watching it in YouTube video form, we hope by the end you have a full grasp on what the CPOT score is, how to do it, including a step-by-step approach, what the numbers mean, how to ensure you're treating the right thing in our critically ill patients. Level up your medical knowledge faster. Join a community of like-minded individuals interested in emergency critical care medicine. Consider joining our YouTube members community. In this community, you will get early access to new videos before they go public, members-only videos including deeper dives, bonus content, study guides, and more, and members-only medical education posts, updates, extra learning resources, and much more. If you're serious about mastering emergency critical care medicine or just want to join a community of like-minded individuals, this is the best way to learn with us every single week. If interested, hit that join button, and I hope to see you inside. Treating pain with pain medication, treating agitation with sedation, identifying delirium, and utilizing ways to curb delirium, all those good things. And that, I hope, will really elevate our approach to these patients. At the end, we do have 3 practice questions as well, but no further ado, let's dive in. What is the CPOT score? Well, CPOT is a validated bedside tool used to assess pain in either intubated patients or nonverbal patients. And to be fair, we most often use this in intubated patients, but there is kind of 2 parallel scoring strategies that you can do in an intubated patient or nonverbal patient. We want to pause here and tease out this definition a little bit. So the first is that it's validated. This means it has been studied. This isn't just some willy-nilly kind of thing people threw together and said, yeah, that sounds good, let's do it, right? It has been validated in the literature as an appropriate tool to assess pain in these populations. It's bedside. Right? This is not a score that you're going to be able to do from the computer, right? You have to go see the patient, evaluate the patient. And it's a tool. That means it's not the end-all be-all. It's an adjunct to the rest of the clinical picture and the rest of your kind of management and diagnostic approach to that patient. It should be a data point within the larger context of that patient's kind of clinical progression. And obviously it's used to assess pain, right? This is a very specific type of condition, right? This isn't agitation. This isn't delirium. This is pain. And we treat these conditions with different approaches, which is why it's so important. So this is used to identify pain. If you've seen any of our other episodes, if you're interested, just search whiteboard medicine, RASS or sedation or something, and you'll get a nice episode on the RASS scoring. We also have a CAM ICU episode, so you can search whiteboard medicine CAM ICU, which is the tool that looks at delirium. So there's different scores to look at these other types of things that could be going on, but the CPOT score is for pain. Okay, so key concept: sedation does not equal analgesia, right? If you're in pain, the treatment is, well, other than also discovering why they're in pain, but the treatment for the pain is analgesia. If you're agitated and it's not because of pain, the treatment might be sedation. And if you're delirious, the treatment, although maybe is going to be related to these two things, but it is not necessarily those two things. So all these are separate syndromes that we approach differently. So why do we use CPOT? Well, intubated patients can't often tell us that they're hurting, right? Some of them can. Some of them are totally awake and can, mouth or write on a sheet of paper that my arm hurts or my leg hurts. But most of them do not maintain that degree of kind of awareness. They can't tell you they hurt. So pain shows up in different ways: tachycardia and hypertension, ventilator desynchrony, grimacing, guarding rigidity, agitation that looks like anxiety. And all these things in our critically ill patients are things we often, kind of like explore more, right? If someone gets tachycardic, we're thinking, oh, are they febrile? Are they septic now? Do they have a PE? Are they hypovolemic? Or in reality, maybe they're just in pain. Same thing with hypertension. They get hypertensive and we're like, oh gosh, we got to put them on an antihypertensive or start nicardipine or something, but maybe we actually just need to treat their pain. Ventilator desynchrony, same thing. We got to switch them to a different mode of ventilation. Should we sedate them? But if we just treat their pain, maybe it gets better, right? You can see the pattern here. We won't belabor the point, but identifying pain can save you a lot of pain, pun intended, of chasing all these other things that might be going on, when in reality, the manifestation that you're seeing is just because the patient's in pain. So CPOT helps you detect pain earlier, treat said pain, and avoid reflexively escalating sedation when in reality you should be treating the pain. So what does the CPOT measure? Well, it looks at behavioral signs of pain across 4 different domains. Okay, domain 1 is facial expressions, domain 2 is body movements, 3 is muscle tension, and 4 is ventilator compliance or vocalizations if they're not intubated. And each one of these categories is scored 0 through 2, and the total score is 0 to 8. Right? So CPOT scoring system is 0 through 8 with 4 domains that can get a 0 or a 1 or a 2. So starting with facial expressions, right? So 0 for all these are going to be, they're not in pain, right? So for facial expression, 0 is their facial expressions is relaxed. They're neutral. They look comfortable. Whereas 1, a score of 1, they're going to be tense. Maybe they're lowering their brows or frowning or tightening their orbits. And then a score of 2, they're going to be grimacing, pronounced facial tension, clenched jaw, right? So you can see that. So 0 is going to be, they look most comfortable. And 2 is going to be, for all these, they look least comfortable. So that's the higher the score, the more kind of signs of pain you are seeing within that domain. So domain number 2, body movements. So 0, which is that they're comfortable, there's no movement, they're normal positioning, they're relaxed. CPOT score of 1 for body movements is protective movements. They're kind of cautious when you're touching painful areas. They might kind of look like they want to protect that area. And 2 for body movements is they're restless. They're pulling at tubes. They're thrashing around because they're in so much pain. Muscle tension, this one can be a tough one, especially in our critically ill patients, because sometimes they get some degree of muscle tension or spasticity or, rigidity, goodness, or clonus, or things depending on their pathology. But a score of 0 is they don't have muscle tension. They're relaxed. You can move all their arms and legs. Things are nice and relaxed and loose. 1 is there's some resistance, and then 2 is they're very tense. They're rigid. They don't want you to move it. But we got to take it within the clinical context, because again, a lot of pathology can cause rigidity as well. And then number 4 is going to be ventilator compliance, or if they're not intubated, vocalizations. But if intubated, are they tolerating the ventilator, right? No alarms. They're nice and compliant. 1 is going to be they're coughing but tolerating. There's occasional desynchrony. They cough every once in a while, but overall things are looking pretty good. And then 2 is they're fighting the ventilator, right? There's all this desynchrony. The alarms are blaring. Our respiratory therapy is in and out of that room nonstop. If extubated, I guess we'll go through this, although we don't classically use the CPOT score in these patients, but you can. 0 would be talking normally, 1 would be sighing, moaning, and 2 would be kind of crying out and sobbing. Okay, so if we go through a step-by-step way that you can perform this through these 4 domains, right? Face, movement, muscle, and vent. Step-by-step, you start by, and we always laugh when we were putting this together, because at Whiteboard Medicine, we're a group of physicians, right? So we certainly will look at the CPOT and talk about the CPOT and occasionally do our own CPOT, but CPOTs are best done by our masterful, brilliant ICU nurses. So if we have any great ICU nurses in the crowd here, let us know. Share with the community your tips and tricks. Let us know if we got anything wrong, because you guys are the real master of it. We are just kind of extrapolating reading and evidence and our anecdotal experience here. Obviously, none of this is intended to be acted upon as medical advice, all that good stuff too. But yeah, if we have any great nurses, share with the community your experiences with the CPOT score. So step 1, observe the patient just at baseline, right? Score them while they're resting. What's their face look like? Are they moving anything? Do they look like they have good synchrony with the ventilator? Step 2, observe them during some type of more uncomfortable procedure. Maybe they're getting suctioning, right? Maybe they're turning or repositioning, wound care, all that good stuff. Because pain sometimes shows up during stimulation, even if at baseline they look okay. And then step 3, reassess them after you have controlled some of their pain. Their CPOT score should be improving with pain control if you're going down the right road, right? It's best used as a trending tool. So do it before, then give them medications if you think they need it, and then repeat it after. If their CPOT score is not improving with pain medication, then it's probably not from pain, right? I suppose you could be underdosing their pain medication as well. But again, this is a trending tool. This is a tool to be used within the larger context of the patient's presentation, and it's something that should be done in series with reassessments. What do the numbers actually mean? We've talked about the 4 domains. We've talked about how to score them. We've talked about some step-by-step approaches, but what do the numbers actually mean? Exact thresholds are going to vary by institution, right? Again, as we always say, this is not intended to be acted upon as medical advice and just used blindly. We got full disclaimers in the episode description and at the end of the episode. And please, read about it, talk to your institutions. All institutions are a little bit different, but in general, a CPOT score of 0 to 2 is often considered minimal or acceptable pain, right? Where a CPOT score of greater than 3, most people would suggest you could consider escalating analgesia. Okay, so 0 to 2 is like the porridge is just right. More than 3, maybe too much pain. Where CPOT fits into the ICU workflow, and we've talked about this a little throughout the episode already, but just to be more explicit, pain evaluations in our mechanically ventilated patients, CPOT scoring. Sedation evaluations in our mechanically ventilated patients, RASS scoring. Delirium assessments in our mechanically ventilation patients, CAM ICU scoring. And we do have episodes on all these. Just search Whiteboard Medicine and then insert which thing you're looking into if you want kind of a deeper dive on all of them. So treat pain first, analgesia first. That's kind of like one of the mantras is we have an analgesia-first approach to patients, so treat pain first, and if pain is adequately controlled, then you can start targeting sedation with RASS, and you should be screening for delirium with CAM ICU. Clinical interpretation of things. Before, I guess we'll rewind. Agitation does not equal anxiety, right? Because they're quote-unquote agitated does not just mean they need reflexively more sedation, right? Before you increase sedation, ask, is the CPOT high? Are they in pain? Do they have a reason to be in pain? And if the CPOT is high, even if the RASS is high, remember RASS was for sedation, but if the CPOT is high, pain may be driving that agitation, and a lot of people would suggest you should treat the pain before you escalate sedation. That analgesia-first approach. Okay, so we do RASS much more frequently, in general, but if the RASS is high, do a CPOT, right? See if they're in pain, and treat that pain first, and that might help their RASS. And if their pain's adequately treated and the RASS is still high and you're trying to target a different RASS, then maybe sedation is the right choice, but don't just throw more sedation at a problem, because it could be pain driving that problem rather than anxiety. All right. Into 3 practice questions. If you have not had practice questions with them before, we have 3 multiple choice practice questions, beginning, intermediate, advanced. We will read the question, read the answer options, and then we go right into the answer. So if you need more time to think about it, just pause the episode, because we'll dive right into the answer after going through the question choices. So question 1, CPOT is most useful for assessing pain in which patient? A patient who's alert, who can self-report pain. B, a nonverbal, mechanically ventilated ICU patient. C, patients being discharged from the emergency department. Or D, a patient who is brain dead. Correct answer is B. CPOT is designed for patients unable to self-report pain, right? So intubated ICU patients are that exact patient population. All right, question 2, intermediate. Which CPOT category is assessed by passive flexion and extension? A, facial expressions. B, body movements. C, muscle tension. Or D, ventilator compliance. Correct answer is C, muscle tension. Right, so remember we have those 4 domains when we're assessing a CPOT score. And it is face, it is body, movements, it is muscle tension, and then that vent, okay? So passive flexion and extension is going to be muscle tension. And then question 3, an intubated patient is grimacing, pulling at restraints, rigid on exam, and frequently triggering ventilator alarms. What CPOT score is most consistent? A, 0, B, 2, C, 4, D, 8. Correct answer is D8. So there's severe findings in all 4 domains, and we'll just write them out. Let's just do it together. So face, we're just going to say movements, we're going to say muscle, and we're going to say vent. So in this patient, the patient is grimacing, right? Grimacing is going to be a +2 score. We can scroll up and just for those watching the video, show people, right? So 0 facial expression, score 0 is relaxed, 1 is tense, 2 is grimacing. So they are grimacing, so they get a +2 for the domain of facial expressions. All right, movement in this patient, they're pulling restraints, they're agitated. That is going to be a +2. We won't scroll up because calm, not flailing or moving is a 0. Some movement is a +1, and then pulling at restraints, pulling at lines and all that, that's a +2. Okay, muscle tension, they're rigid, right? Rigidity is +2. Some resistance is +1, and loose and relaxed is 0. And then they're frequently triggering alarms. We said no alarms is 0. Alarms every once in a while with suctioning is +1, and then frequently triggering alarms is +2. So this is a CPOT score of 8 that suggests they're probably in pain, and pain should be treated. Hey everybody, and welcome back to another episode here at Whiteboard Medicine. We appreciate you checking it out. Hope everybody is having a good day so far. Glad we're all learned together. We are just coming off a week of rounding in the medical intensive care unit. It was a good week. This is obviously a topic very pertinent to that week. And the topic today for this episode is RASS scoring, Richmond Agitation-Sedation Scale, RASS, RASS. So that's what we're going to be talking about today. Hopefully by the end of this you have a full grasp on what RASS is, how it's used, how it can benefit patients, how it's calculated, some of the tips and tricks, all that good stuff. So no further ado, let's dive in. What is RASS, Richmond Agitation-Sedation Scale. If I could borrow a quick 60 seconds of your time, I wanted to introduce you to a community we're really excited about building, and that is our Patreon community. In this community, you will get access to high-yield medical education posts, ad-free videos, study guides, practice questions, mini courses, book chapters, and much more. You will see that by joining this community, you will get access to the PDFs, the study guides for every single YouTube video. Here's an example of one of those right now. In addition to that, you will get access to mini courses. In these courses, we will have videos, study guides, practice questions, bedside tips and tricks, and 30 practice questions at the end to test your knowledge. In addition to that, we have collections on every major emergency critical care topic that contains videos, medical education posts, practice questions, study guides, all categorized. And lastly, we have book chapters. These book chapters are high-yield clinical reviews, such as this one on the basics of mechanical ventilation. Beyond that, we have ad-free videos, we have practice questions, and we are constantly innovating and integrating new resources for you all. If you have a passion for emergency critical care medicine like us, consider joining this community today. In it, we hope that you will find all the resources necessary to push your knowledge to the next level and really improve the bedside care of these critically ill patients. Well, it's a validated bedside tool used to assess a patient's level of alertness, agitation, or sedation depth. And this has a lot of kind of big, meaningful words in it that we want to tease out a little bit more. And the first thing here is validated is quite important. It's just a little word, but this means it's studied, right? There's research, there are trials on using RASS, and they have validated its use. It's not something that people are just kind of using willy-nilly. People actually studied it and found that by using RASS, we can potentially improve some outcomes, which we'll get into later on in this episode. And it's a bedside tool. So you use this at the bedside with the patient. It's not something you get from the lab work or just the vital signs. You can't figure it out from your computer. You got to go to the bedside and you got to actually look and evaluate the patient itself. And then at the end of the day, it is a tool. This isn't, the end all be all. This one number, the RASS, isn't just this kind of magical isolated thing you should act on, but it's a tool. It's meant to be an adjunct to the rest of your kind of clinical assessment. All right, and it's used to look at level of alertness, so how awake is the patient, are they agitated, and what their sedation depth is. And most commonly, as we kind of hinted at the beginning of this episode, it's used in ICU patients. And the patients it's most often used on in the ICU are intubated and mechanically ventilated patients. So that's kind of the most common patient population. Now, you can theoretically use it on non-intubated patients as well, but anecdotally, in our experience, it tends to be used on intubated patients. And obviously, as we always say, none of this is intended to be acted upon as medical advice. We certainly have the full disclaimer in the comments and at the end of the episodes. But that's kind of the anecdotal experience here. Okay, so kind of when we try to circle and create it into a key idea, RASS is kind of the language the ICU team uses to communicate sedation goals. It gives us kind of standardized language, something we can repeat, all understand, all talk about, to try to aim for the right depth of sedation in our intubated patients in the intensive care unit. All right, why do we use RASS? Well, hopefully we're starting to fill in some of these gaps as we have been talking, but the main purposes here are to standardize the sedation assessment. And standardization is really important, right? Because it helps us speak the same language, and that does a couple of things. One, all members of the bedside team, nurses, respiratory therapists, medical assistants, physicians, APCs, whoever is part of that healthcare team, we all can understand what RASS is, and as such, we all can understand what the RASS number means for our patients. So it's not, what is your interpretation of, they're, moderately sedated or they're lightly sedated, right? Those kind of subjective terms can lead to incorrect assumptions by other members of the healthcare team who maybe have a different interpretation of what mild sedation means. So RASS tries to objectify that. It tries to give us a standardized language to all I'll talk about when speaking about sedated patients. It also gives us an actual objective number, right? And by giving us an objective number, it helps us prevent over sedation and under sedation for that matter. And we'll get into this more, but the right depth of sedation can really affect outcomes. Overly sedated patients, it's well validated in the medical literature that these patients who are oversedated have prolonged ventilator stays. Prolonged duration of mechanical ventilation, prolonged ICU length of stays, more adverse effects from the sedation like hypotension, more delirium, which can be really significant. And, on this, on our channel, we talk about the CAM ICU score as well, CPOT, some of these other things. But preventing over sedation is really critical. It also can prevent some degree of undersedation. At the end of the day, there's a lot of discussion on what the right sedation depth is for patients. Do our patients even need sedation? The answer to that's probably that they don't, and we probably are a little heavy-handed with our sedation, but at the same time, having patients agitated and flailing and pulling at their tube and in distress probably is also not the right thing. So, it gives us an objective number to at least track that. And then third, is that this number is repeatable. So when it changes, that something has changed, right? If the patient's been at a RASS of 0 this whole time, and all of a sudden their RASS goes down to -4, and you did not change the sedation, well, that might mean that, although they look more sedated, maybe something catastrophic has happened to their intracranial pathology. Maybe they had a big spontaneous brain bleed or a stroke or something that caused significantly diminished awareness because their RASS had dropped without us changing any of their sedation medications. So kind of the change in RASS, the trend over time can be important too. So let's get into what the RASS scale actually is. So it goes from +4 to -5. And positive numbers are more awake, negative numbers are more sedated. So how do we actually do it? Well, we obviously don't get, we don't have any sponsors on this channel, but MD Calc has many kind of measures and scales and things you can just click numbers. So this is not an endorsement for MD Calc. Again, we don't get any money from MD Calc. But as with many of our measures, they have RASS things. So you always can search MD Calc RASS, and then excellent bedside nurses probably have a lot of this ingrained into their brains because they're doing it all the time. And there's certainly some EMR cheat sheets to help enter RASSes into the computer. But for this lowly physician with a small pea-sized brain, sometimes we just MD Calc RASS to remind ourselves what the different numbers correlate to. So starting with positive numbers, the most agitated states, +4 is combative, right? +4 is this is a patient who's flailing, they're fighting, they're pulling lines, they are coming off as a danger to themselves or staff, not because they're actually trying to hurt someone, but they might just be so agitated, so delirious, so sick that they are a danger to themselves and staff. So +4 is the highest, and it is incredibly agitated, combative. +3 is the kind of step right below that, right? So they're very agitated. They are pulling at tubes and lines. They're not very redirectable. They maybe have some aggressiveness to their behaviors. Again, not intentionally, unintentionally, but that's how agitated they are. But they might not be, wildly flailing, immediate danger to staff, that kind of stuff. So +3 is still very agitated. So if someone is at a +4 or +3, their sedation is not going well, right? These are patients that we need to get into a safer place. +2 is mildly agitated, okay? So they might have frequent kind of non-purposeful movements. They might kind of fight the ventilator a little bit. They might appear anxious, but they're not, having aggressive behavior. They're not trying to pull up their lines. They are redirectable. So +2, we're getting closer to kind of the goal, which is what we'll get into after this. +1 is just restless. Might be anxious, might be apprehensive. Movements are not aggressive. They're not kind of robust and violent, but the patient's just restless. They're a little anxious. They're on a ventilator. And they, are awake enough to feel some of that anxiety or apprehension. A RASS of 0 is kind of the porridge is just right RASS. So they're alert, they're calm, they're awake. Excuse us. They make eye contact with you. This RASS 0 is kind of where the magic happens, right? That's where we want all of our patients. We want them awake, we want them calm, we want them comfortable, we want them able to interact. So that RASS of 0 is that number there. And then we get into the negatives, and the negatives correlate with less than alert and calm, right? So they're a little sedated. So RASS -1 is drowsy. They're not fully alert, but they'll awaken to voice. They make eye contact for greater than 10 seconds, which is an important kind of objective measure. So this is also another one where it's where the magic happens, because I guess we'll just say it now, but we'll explicitly say it later. The goal RASS in most patients is a RASS of 0 to -1. So this calm, collected, awakens to voice, keeps eye contact, 0 to -1 is what we often are targeting. But there's some exceptions to that, and we'll get into the exceptions as well. -2 is light sedation. They briefly awaken to voice, but they're not going to hold eye contact for more than 10 seconds. So this is, again, an important differentiator between RASS of -1 and RASS of -2. RASS of -1 maintains eye contact for greater than 10 seconds. RASS of -2 does not maintain eye contact for greater than 10 seconds. But RASS of -3 is moderate sedation. So we do not make any eye contact when we're RASS of -3. We might open our eyes, we might move a little bit to voice, but no eye contact. And then RASS of -4, now we're getting into deep sedation, right? If you hear people saying, let's target a RASS of, -4 to -5, this is deeply sedated patients, because a RASS of -4 is there's no response to voice. They're not opening eyes, they're not moving to voice, but if you give them a little physical stimulation, a little noxious stimuli, they will move, but this is not happening spontaneously to voice. And then RASS of -5 is, unarousable. There's no response to voice, there's no response to physical stimulation. This is deep sedation. So if we get into how to perform the RASS itself, now that we've talked about the numbers, we wanted to try to lay out kind of a step-by-step guide. And any of our awesome ICU nurses in this community, definitely drop in the comments what your thoughts are, because we are a physician team over here, and as many of you listening probably know, I think at most institutions, the physicians are not the ones performing the RASS all the time, so our awesome ICU nurses are much better at that than we are. So let us know what tips and tricks y'all have in the comments too. Share them with the group here. So RASS, step 1, when we were, kind of reading about what we do in our day-to-day, would be just starting with step 1, observe the patient. Don't stimulate them, just observe them. Are they awake and are they calm, looking around? Well, that right there is a RASS of -0. That's great. But if you're looking at them and they're agitated and they're restless, their score's already going to be +1 to +4. So you kind of have already categorized them into the plus category. Whereas if you're observing them and they look, eyes closed, not moving, completely out of it, that's going to be a RASS, -5 to -1. They're going to be in the negative side of the RASS. So just observe them at first. And that'll help let you know, are you going to be kind of in the negative or the positive portion of the RASS scoring system. So then step in and use voice. Use your voice. Say, open your eyes. What's your name? Look at me. And if they, I guess we should rewind. So if they are not awake and alert when you're just observing them, this is when voice is helpful, right? If the patient's in there flailing around screaming, you don't need to say, open your eyes, look at me, because you already know the RASS is on the plus side. So step 2 would be for the patient who is not looking around, not awake. You go in the room, you use your voice, you ask them, open your eyes. If they maintain eye contact for greater than 10 seconds, their RASS is probably -1, right? If they can't maintain eye contact for 10 seconds, their RASS is going to be less than -1, right? But if they do make eye contact with you at all, they're going to be in that 1 to 2. So to lay this out, you observe them from the door. You said, okay, they're flailing, they're trying to punch people, they're pulling out their lines, they're screaming. Their RASS is already going to be +4, okay? But you observe them from the door and their eyes are closed, they're not moving. Are they sleeping or are they overly sedated? It's unclear. So then you walk in the room, you say, hey, open your eyes, look at me. If they make eye contact for greater than 10 seconds, their RASS is -1, okay? If they open their eyes to voice, look at you, but make eye contact for less than 10 seconds, their RASS is -2. If they open their eyes to verbal stimuli but do not make eye contact with you, their RASS is going to be -3. So that second step here, using voice and asking them to look at you, will help differentiate a RASS of -1 to -3. But if there's no response to voice, then you have to move on to physical stimulation, right? So, shake their shoulder, sternal rub if appropriate. And if they move to that stimulus, their RASS is -4. If they don't move, it's -5. So hopefully that makes sense, right? You start with a RASS of 0, you go to RASS of -5 on the negative end, right? The positive end is that they're agitated, which you just RASS score them based on degree of agitation. But from the door when you're observing them, if their eyes are open, they're looking around, they look calm, it's a 0, right? If they are eyes closed, not moving when you're observing them, then use voice. And voice will tell you, are they -1, 2, 3, 4, or 5. If they open their eyes for 10 seconds, make eye contact for 10 seconds to your voice, RASS of -1. If they make eye contact with you, but it's less than 10 seconds to voice, RASS of -2. If they open their eyes and look around to voice, but they don't make eye contact, RASS of -3. If they don't open their eyes at all to voice, that is when you then go to kind of the physical stimulation. And if they move around to physical stimulation, RASS of -4. If they do not move around to physical stimulation, their RASS is -5. Okay? So do note that patients have a lot of variability in this, so the RASS depends on the best response to stimulation. So if you're in there, you're saying their name, they're not opening their eyes and looking at you, and then all of a sudden they do on the third time, and they make eye contact with you for more than 10 seconds, the RASS is still -1, even if they, didn't do that when you said their name the first 2 times. All right, let's get into typical sedation targets. So most ICU patients were targeting a RASS of -1 to 0, kind of that quote unquote light sedation. And this has been validated in trials, and it helps with earlier weaning and extubation off the ventilator, less delirium, early mobilization, fewer sedation complications. So this is really important. There's obviously that slippery slope. Our patients are really sick. They're on the ventilator. No one wants to look at their patient uncomfortable. Patients change over time, and often patients probably end up on deeper sedation than they should be. But part of that is because patients change throughout the day, right? Patients might need a little more sedation 1 hour, a little less sedation the next hour, et cetera, et cetera. So this is a constant moving target, which is why RASS scoring is so important, because it helps us try to keep within that 0 to -1 target. And outcomes are better, right? Deeper sedation, deeper than is necessary, does worsen outcomes. It does increase delirium. It does prolong mechanical ventilation. It does prolong ICU length of stay. So it's really important that in the right patient, we target that appropriate RASS. But sometimes we do intentionally aim deeper. And deeper sedation is going to be a RASS of -3 to -5, obviously -5 being the deepest. And as a reminder, what is -5? Who can think of it? -5 is even with physical stimulation, there is no movement. The patient does not move. What is -3? -3 is voice. They'll open eyes, but they won't look at you. So just to keep the longitudinal learning here going. Okay, so some conditions we aim for deeper sedation, and a few examples that pop up here are like severe ARDS. We still want the lightest sedation tolerable with severe ARDS, but sometimes these patients, if you're proning them or they're on very high vent settings, and you start getting a lot of vent desynchrony or tachypnea or things that are increasing ventilator-induced lung injury, you might more deeply sedate them. But having severe ARDS in and of itself is not an indication to just reflexively deeply sedate them. Refractory ventilator desynchrony. We've talked about ventilator desynchrony a lot on this channel. Just search whiteboard medicine and choose whatever you want. Flow, starvation, double triggering, reverse triggering, auto PEEP, ineffective triggering, all that kind of stuff. And we've put episodes out on that. And we talk in those episodes a lot about how to appropriately manage ventilator desynchrony by adjusting your ventilator settings. But some patients, despite doing, everything you cannot get them synchronous with the ventilator, and it might start causing ventilator-induced lung injury, right? If you cannot, for the life of you get them to stop double triggering so they're getting 2 breaths at once, that is going to cause more ventilator-induced lung injury. So sometimes, and it should be the last resort, but sometimes a little deeper sedation in the right patient for ventilator desynchrony is indicated, but we do pull that trigger too quickly. So don't take this as a suggestion that you should be deeply sedating anyone with vent desynchrony. You should not. That's the wrong thing. But some of those patients, if it's in the right clinical context, you may have to. All right, if you're doing neuromuscular blockade, we do this less than I think we used to. There's 2 trials, especially in severe ARDS, the Accurasis and Rose trial. And Rose, suggested that maybe a neuromuscular blockade wasn't as helpful for ARDS patients as we thought. But if you're going to paralyze somebody, put them on neuromuscular blockade, they need to be deeply sedated, right? Because once they're paralyzed, you won't be able to do the RASS score. So that's maybe a good point just to explicitly point out. If a patient is paralyzed, you cannot RASS score them, right? Because they are paralyzed. They're not moving. So you need to get them deeply sedated before you do neuromuscular blockade. This is really important, right? Think about how terrifying it would be to be on a vent paralyzed without appropriate sedation. Status epilepticus, sometimes if we cannot control seizures, we will end up suppressing them with high doses of sedation. And then elevated ICP and severe TBI, in some instances, again, you might deeply sedate a patient. So deep sedation should be a reasoned choice, something everybody talks about and makes a clinical decision. It should never be the default. So just speaking in general, there's an analgesia-first approach to pain, sedation, agitation in the intensive care unit for mechanically ventilated patients. You want to be treating their analgesia first. This is something we'll talk about in another episode. But RASS fitting into this, before you increase sedatives, right? Before you say their RASS is because they need more sedation, right? Maybe their RASS is +2, and you're like, gosh, they're agitated, they're, moving around a lot, they look very uncomfortable. Don't just reflexively say increase sedation, especially if on that dose of sedation, their RASS was okay. Maybe 6 hours ago, their RASS was 0, and you didn't change their sedation around, and all of a sudden their RASS is +2 now. Do not just reflexively increase their sedation. Always ask, is the patient in pain now? Is something else changing, right? Are they hypoxic, acidotic, febrile, withdrawing? Did the ventilator settings or mechanics change? So trending that RASS number is important, but don't interpret the trend as a reflex to increase sedation. Reassess if something has changed, if that RASS changes despite their sedation doses not changing. That's critically important. All right, to end, we for a handful of episodes, we would do practice questions at the end. We didn't hear a whole lot of feedback from our community on that, so we started not doing it because we just assumed that maybe meant that people weren't that into it. But then we got a comment or 2 the other week where people were like, oh, we loved the practice questions, so we're going to put them back in. 3 practice questions at the end of each episode. The way that these practice questions work is we'll read the question, we'll read the answer options, and then we just go right into the answer. So if you need more time to think about it, just make sure to pause the episode. All right. We have varying intensity. It starts with beginner, then intermediate, then more advanced. Question number 1. A ventilated patient opens their eyes to voice and maintains eye contact for 12 seconds. What is the RASS? Option A, 0, B, -1, C, -2, D, -3. Remember, pause if you need more time. The correct answer is -1. So remember, we said patients, let's just list these out. 0, -1, -2, -3 for RASS. 0 is the patient is spontaneously opening eyes, they're maintaining eye contact, they're calm. So this patient opened eyes to voice. So they're not 0, right? Because 0, you don't open eyes to voice, you spontaneously open eyes. Now let's go to -3. -3, we said, is you make no eye contact, but you do open eyes to voice. So that patient, when you say, hey, look at me, you don't make eye contact, but you do open eyes to voice. So this patient opened eyes to voice and maintained eye contact for 12 seconds. So it's not -3. So then we're -1 and -2. And remember, -1, eye contact is greater than 10 seconds to voice. -2 is eye contact is less than 10 seconds to voice. We said that it was 12 seconds here. So it is the RASS of -1B. All right, question number 2. A patient does, hopefully you didn't just see the answer. A patient does not respond to voice but withdraws to sternal rub. What is the RASS? A, -3, B, -4, C, -5, D, +1. Pause if you need to. The correct answer is B, -4. So Again, let's write them out. -3, -4, -5, and then they put +1 in there, or I guess we did. So just to cover +1, right? +1 is that you are a little anxious. It's on the plus side. You are awake spontaneously. You're anxious. You're a little uncomfortable, maybe. Actually, that's not fair. We're just going to say anxious, a little apprehensive. This patient does not respond to voice, right? So they're not a +1. That leaves us with -3 to -5. On the far end, -5, this is a patient, remember, who even with physical stim does nothing. They don't move, they don't open their eyes. -3 I always talked about. -3 was actually with voice, you open eyes. So this patient, we said, does not respond to voice. So it can't be -3. But they do withdraw to sternal rub, right? -5, you don't withdraw, so it's not -5. So it leaves us with -4. -4 is with voice, you do not open your eyes, but with noxious stimuli, you do withdraw. So they sternal rubbed and they withdrew. Last question, question 3. Which RASS target is most appropriate for a stable intubated patient without ARDS or neuroemergency? A, +2, B, 0 to -1, C, -4 to -5, or D, RASS cannot be used in intubated patients. Hopefully no one chooses that. Correct answer is B, 0 to -1, right? This is that light sedation. This is what is studied and validated to potentially be the most effective in decreasing ventilator duration and ICU length of stay and all that kind of stuff. So B, 0 to -1 is where the porridge is just right for the majority of patients, assuming there's not another clinical indication. Hey everybody, and welcome back to another episode here at Whiteboard Medicine. We appreciate you checking it out. Hope everybody is having a good day. We just recently came off a week of rounding in the medical intensive care unit. Lots of patients receiving what we're going to be talking about today, and that is Propofol in the mechanically ventilated patient. This is an incredibly common medication that we use to assist with sedation in the mechanically ventilated patient. It's one that we really should know a lot about, and the hope is by the end of this episode that you will have a full grasp on all things Propofol, what it is, how it works, how to dose it, adverse effects, monitoring, and we'll end with a couple practice questions as well. As always, this is not intended to be acted upon as medical advice. This is all conceptual and educational. Certainly check out your local guidelines and do your own research and all that good stuff. No further ado, Propofol. So what is Propofol and what it is not? Well, Propofol by category is a sedative hypnotic, and it's used, at least in this case, for rapid titratable sedation in mechanically ventilated adults. It's a very common medication we use for sedation in mechanically ventilated adults. And from a bird's eye view, it's really great for quick on and off sedation, right? It's fast acting. It when you turn it on, gets to therapeutic thresholds quickly, and when you turn it off, it works its way out of the system quickly, which makes it really nice for patients on mechanical ventilation because you're making a lot of real-time changes, right? Sometimes hour to hour, sometimes, 5 to 10 minutes to 5 to 10 minutes, you might be titrating the Propofol. And if it takes 30 minutes before it kind of reaches its therapeutic threshold in one way or another, that's obviously not going to be useful. And the other thing is, every patient we have sedated, we want to do a sedation vacation and spontaneous breathing trial, obviously for those that are safe to do that. So if the medication sticks around in someone's system for hours and hours, stopping the sedation is going to still preclude you from doing a spontaneous breathing trial if they still have a bunch of sedation circling around. So the fact it's quick on and quick off is really, really useful. The one thing to note is that Propofol, from a mechanism standpoint, is not an analgesic. It does not treat pain. So in patients who are on mechanical ventilation, we often talk about this Analgesia-first strategy, and we talked about, the RASS score and CPOT score, and even the CAM ICU score for Delirium. If you have an interest in learning about any of that stuff, just search Whiteboard Medicine, insert which one you want to learn about, because we go over all of that. But we often do this kind of Analgesia-first strategy in our mechanically ventilated patients because we want to make sure we are treating pain first before we just try to sedate the pain out of them. So just know Propofol is not an analgesic. It does not treat pain. And we often pair it with an analgesic medication, sometimes things like fentanyl when needed. And not all patients do need that, right? Not to suggest everyone should just end up on these medications blanketly. And not every mechanically ventilated patient needs Propofol or, any sedation for that matter. This is all very, very patient specific. But just note, you are not treating pain with your Propofol. So mechanism of action, how does Propofol work? Well, Propofol primarily potentiates GABAergic receptor activity, specifically GABA A. So it is a GABA A receptor agonist. And this increases the amount of inhibitory neurotransmission, causing hypnosis and sedation. Now, propofol does have some other CNS effects. These, aren't as clinically testable and probably don't play as much of a clinical role. The key mechanism here is that it's GABAergic. And this is also important to note for other things, right? If a patient is intubated because they were having seizures, propofol is GABAergic. You have to get it to certain doses to treat something like status epilepticus, but it does have that GABA activity. Or alcohol withdrawal, right? We give GABAergic medications. Propofol might be a nice medication in those instances too. So GABA is the primary mechanism of action and the one that we most often focus on. So what are our clinical goals when we are starting propofol sedation? Well, the target in patients on mechanical ventilation, at least the vast majority of them, would be, quote unquote, light sedation. And this gets into RASS scoring, Richmond Agitation-Sedation Scale score. And again, this is something we talked about. Just search whiteboard medicine, RASS, and it'll pop up. We're not going to go through it in detail today, but our RASS goal in these patients often is -1 to 0. And that's that kind of comfortable, not anxious, but also awake, opens eyes to voice, makes eye contact, can interact with you. That's kind of that RASS of -1 to 0. And to do this in a patient who's having agitation anxiety and it's not driven by pain, propofol is one of our first options to assist in getting that patient to that nice RASS of 0 to -1. Again, not every patient needs it. Not every patient on mechanical ventilation needs sedation. It is a tool, not a blanket suggestion, but that is fairly common in the ICU world. Now, at times there is reason to go to a deeper sedation level. Sometimes severe ARDS, refractory desynchrony of the ventilator, status epilepticus, ICP crisis. If you're paralyzing a patient, they require deep sedation. All these are obviously very patient dependent, other than paralysis, which, in a patient who is paralyzed, they should be deeply sedated. But otherwise, a lot of this is, patient dependent. You certainly shouldn't try to sedate the desynchrony of the ventilator out of your patient without first trying incredibly hard to adjust ventilator settings to be more comfortable for the patient. You all get the gist, right? But sometimes you do have to go to a deeper sedation. The RASS is 0 to -1. Deeper would be a more negative RASS, something like a RASS of, -3, -4, and then -5 is, they're not even responding to noxious stimuli. So deep sedation. But the clinical goals when we start propofol sedation often are to target that RASS of -1 to 0. So dosing and titration. We just want to extra point out, right, this is conceptual and educational. Don't just blanket accept these doses. Do your own reading, look into your institutional guidelines, and make your own clinical decisions. All right, sorry to be a broken record. So typical infusion dosing, if we were just to talk from an educational standpoint, often it's started at 5 to 10, and it's dosed in micrograms per kilogram per minute. So it is weight-based dosing. All right. And we usually will titrate it by 5 to 10 micrograms per kilogram per minute every 5 to 10 minutes until you get to that target sedation. Again, often that RASS of 0 to -1, although sometimes deeper than that. Common maintenance ranges are usually somewhere in the realm of 5 to 50 micrograms per kilogram per minute. Anything more than 50 micrograms per kilogram per minute would be considered, quite heavy sedation from a propofol. I shouldn't say sedation, quite heavy dosing from a propofol standpoint, but it certainly varies by patient and by goal, right? You sometimes will be on higher doses, but this is a nice kind of rough range of where these patients often end up. The packaging label at times, depending on what you're looking at, has anywhere from 25 to 100 micrograms per kilogram per minute, but we're going to cross that out and go with what we wrote above. Okay, so boluses, we just wanted to kind of shout this out. You can bolus propofol. Depending on your institution, nurses sometimes can do it, sometimes can't do it, but propofol can be given in bolus form. It will rapidly deepen sedation. We're not suggesting you do or don't do this. There is more risk, right? Hypotension, apnea, all that kind of stuff, but it is a medication that can be bolused. Reassessments are really important, right? You are potentially titrating this every 5 to 10 minutes. So frequent RASS reassessments, if that's what your institution is using to monitor sedation depth, should be done. And then after you reach stability, right, you have someone who is at the targeted RASS at a certain dose of propofol, you still want to reassess on a schedule, right? Because there will be clinical changes. Our patients in the ICU who are sick are very dynamic, and things change, right? They get sicker, they get less sick, they get more agitated, less agitated, all that kind of stuff. So reassessments are persistent throughout, even after you feel like you have reached a stable dose. All right, we did a lot of scribbling. For those of you watching the video version of this, hopefully it was directional rather than just chaotic. All right, what's next? What to monitor while on propofol. This is critically important. We use this medication a lot. What should we be looking out for? Well, always watch blood pressure and heart rate, right? Propofol can cause hypotension. Now, that's not to say you should shut the propofol off with hypotension just reflexively, but no, it will contribute to it, right? So maybe you should shut it off, or maybe you have to bridge them with some vasopressors depending on what's going on, but it will cause hypotension. And then propofol causes bradycardia as well. Now, dexmedetomidine is more kind of classic for bradycardia, but propofol does cause bradycardia too. So always be watching the hemodynamics, both heart rate and blood pressure. And then just to be a broken record, obviously you should be always monitoring your RASS as well. When you are on prolonged or higher doses, there's a couple different things that can happen. The main one is it can increase triglycerides, okay? Propofol is part of the medication solution, has fats in it. So depending on your institution, you might do it differently. I think many institutions, if you're on propofol, test triglycerides every 48 hours. Again, every institution is going to be different. Some institutions start to get worried when those triglycerides go above 300. Some start to get worried when they go above 500. But nonetheless, propofol can cause hypertriglyceridemia. Hypertriglyceridemia can cause things like pancreatitis, right? So it's not just that we, are just sent in the lab for no reason. So it can cause negative effects as well. And then the other thing to note, and this is not that common, but propofol infusion syndrome, sometimes people abbreviate it PRIS. This can actually be deadly. It happens in patients who are on prolonged high doses, but it can cause rhabdo, acute renal failure, lactic acidosis, severe metabolic acidemia. Some institutions trend CPK, some institutions do not, but it is a reasonable thing to do to monitor for things like PRIS. All right, adverse effects, the must-know list. So this is kind of getting into the nuances of the adverse effects. We said hypotension, very common. Propofol causes some vasodilation. It also might cause some myocardial depression. And this might be worse in patients who are already vasoplegic or hypovolemic. So hypotension, very common, monitor for it. Bradycardia, like we said, it is less common. We see it more often in dexmedetomidine, but it can happen and it can be clinically important, right? You have a patient who starts on propofol and they get bradycardic. You should consider, is that the propofol? We talked about hypertriglyceridemia. Propofol is in a lipid emulsion. Triglyceride elevation is not rare in ICU use. This is something we do see and you will see. If you do not monitor triglycerides, you will miss it. And then at some point, the nurse or someone will say, oh gosh, this blood looks weird. There's like a white layer settling in it. And it's because you missed profound hypertriglyceridemia. So trend it, watch it, it will happen. Pancreatitis, in the setting of the high triglycerides, again, is there a relationship there? Is there not? Tough to say, but there is triglyceride-induced pancreatitis, so it's something to think about. And then the very rare but the highest stakes, the thing that is the most deadly is propofol-related infusion syndrome, or PRIS. It's potentially fatal, and as we said, it causes rhabdo, metabolic acidosis, acute renal failure, elevated lactate, and this can spiral so bad that can cause cardiovascular collapse, and this can be deadly. Again, some institutions trend CPK, some don't, but even if you're not, if you see someone who has, an undifferentiated lactic acidosis, they're extremely acidemic, they're developing AKI, you might be like, gosh, could this be propofol infusion syndrome, in which case sending it CPK wouldn't be unreasonable. Now, in our critically ill patients, a lot of things can cause lactic acidosis, acidemia, and AKI, but it is something that should be on the differential, especially for patients on higher doses or prolonged infusions. Oh, look, we read our own mind when we made this. Risk increases with higher doses and longer durations. Reviews commonly cite avoiding very high infusion rates and prolonged infusions when possible. Good. Okay. Other things, injection site pain, not as relevant for us. Some patients can develop green urine. It's not common, but it can happen. And then it's a lipid emulsion, right? So your nutrition or dietary folks, or if you're doing your calculations on yourself about tube feed and caloric requirements, often if you're on propofol, you will have kind of a decreased rate of tube feeds, which means once you discontinue the propofol, you need to increase that rate of tube feeds because there's a lot of calories in propofol. Contraindications and relative no's. This is just, maybe something more interesting than anything else. Hard contraindications, not to be annoying, but obviously someone who has known hypersensitivity to propofol or its components. There is a little nuance here, okay? So in propofol, egg yolk, one of the molecules is called, oh boy, let's see if we can remember this. I think it's lecithin, something like that. Keep us honest. You can put in the comments if we got it wrong. But this is in propofol. So patients with allergies to egg products or soy products, sometimes it will be listed that they're allergic to propofol. Again, this is not medical advice. There's many studies on this. It seems like it's not as simple as that and probably isn't as straightforward as that. And many patients with egg allergies don't react to propofol, but some do, and it is sometimes still listed on labeling, so something to keep in mind. But it's because of this lecithin here. Some allergy organizations argue that these allergies don't translate to propofol reactions, and many can receive propofol safely. So local policy and severity, right? If it's an anaphylactic allergy, rolling the dice maybe is a higher risk, but yeah, do what you want with that. Okay, relative cautions. This is one that's commonly listed. We have our own personal opinions on this. Profound shock and hemodynamic instability. In our humble opinion, right, propofol is still okay. You just have to bridge their hemodynamics. Like if someone is agitated, going crazy on the ventilator and needs sedation, I would still give them propofol rather than, Versed, midazolam, or something else. But it will worsen hypotension, so choose your own destiny there. Situations requiring prolonged deep sedation at high doses, you just got to be careful of that PRIS risk. And then someone with hypertriglyceridemia, right? We just had a patient who had hypertriglyceridemia-induced pancreatitis in addition to a number of other things, and they obviously shouldn't be on propofol because their triglycerides were already very, very high. If we reflect on the guidelines a little bit, the guidelines, SCCM, Society for Critical Care Medicine, recommends propofol and dexmedetomidine over benzodiazepines, right? Midazolam is not recommended as first line, just to note. And then, some focus updates talk about using dexmedetomidine over propofol if light sedation or delirium reduction is the aim, but it's, moderate evidence conditional. Head-to-head outcomes, a large randomized trial found no significant difference between dexmedetomidine and propofol in days alive without delirium or coma. So practically speaking, propofol remains a core first-line sedative in patients on mechanical ventilation. It's fast, it's titratable, but just be intentional, right? And be intentional about monitoring your RASS, be intentional about dose duration, hemodynamic monitoring, trending important blood work like triglycerides, and monitoring for any contraindications or risks. Alrighty, we're getting closer. Here's a rough approach on the vent just for educational purposes. So decide your target RASS. Many people, that's 0 to -1. Treat pain first, right? Don't try to sedate the pain out of the patient with propofol. If pain is adequately treated, maybe you're using your CPOT score. Again, search Whiteboard Medicine CPOT, and we got some episodes on that. Start propofol. Typical starting doses from an educational standpoint are 5 to 10 micrograms per kilogram per minute. You can titrate at Q 5 to 10 minutes. If blood pressure drops, reassess volume status. Consider reducing propofol dose if you need to. You could switch strategies if a patient is amenable to another strategy. Monitor triglycerides. Watch for signs of PRIS. All right, shall we end with 3 practice questions? For those of you that have not done practice questions with us, we have 3 of them. First is beginner, second is intermediate, third is advanced. We will read the question as well as the answer options, and then we'll go right into the answer. So if you need more time to think about it, just pause the episode because we're going to dive right into the answer. Question 1, beginner. Propofol's primary sedative mechanism is best described as A, an NMDA receptor antagonist, B, a mu opioid receptor agonist, C, a GABA A receptor potentiator, or D, a dopamine receptor antagonist. Pause if you need to. The correct answer is C, right? Propofol primarily potentiates GABA A signaling, which we talked about. Okay, intermediate, question 2. A reasonable ICU titration strategy for propofol sedation is A, start at 50 micrograms per kilogram per minute and adjust hourly. B, start at 5 to 10 micrograms per kilogram per minute and titrate by 5 to 10 micrograms per kilogram per minute every 5 to 10 minutes to a RASS goal. C, use propofol alone because it provides analgesia. D, avoid reassessing sedation once the infusion is started. The correct answer is B, right? We said propofol is fast on, fast off. Start at 5 to 10 from an educational standpoint. Titrate Q 5 to 10 mins by 5 to 10 and titrate it to your RASS goal. Okay, starting at 50 would be way too high. Using propofol alone to provide analgesia does not provide analgesia, and obviously you want to keep reassessing once sedation started. It's not a set it and forget it. Last but not least, question 3. A mechanically ventilated patient on high-dose propofol for 2 days develops worsening shock, rising lactate, metabolic acidosis, and marked elevation of their CPK. The most concerning diagnosis is A. Malignant hyperthermia, B. Neuroleptic malignant syndrome, C. Propofol-related infusion syndrome, or D. Serotonin syndrome. Oh gosh, if you're watching the video, we left a check mark on here, so you know the answer already. But if you're not watching the video or not paying attention, C is the correct answer, Propofol-related infusion syndrome. So, to be fair to you, if you chose something else, we didn't provide a lot of context, but this presentation would be classical for propofol-related infusion syndrome, right? You get a lactate, you get acute renal failure, you get metabolic acidemia, and you get rhabdo. Malignant hyperthermia would be profound fevers in some of these findings, but while they go randomly into malignant hyperthermia, we could say that they're not on any antipsychotic drugs, so neuroleptic malignant syndrome less likely. Serotonin syndrome, often clonus, is a classical finding, and we could just say they're not on serotonergic medications, although to note, fentanyl has some serotonergic activity if the question stem was different. All right, everybody, welcome back to another episode here at Whiteboard Medicine. We appreciate you checking it out. Hope everybody's having a lovely day, lovely weekend, lovely evening or morning, depending on when you watch this. Today we're going to be diving into the beloved Dexmedetomidine, brand name Precedex, in the mechanically ventilated patient. This is a really important topic. Dexmedetomidine has really exploded in its use cases, and there's some decent data behind it as well. And you are going to be seeing this whether you are in the emergency department with critically ill patients, those on mechanical ventilation, or up in the intensive care units. You definitely will come across this. So by the end of this episode, we hope you understand what Dexmedetomidine is, what it isn't, how to use it, how to dose it. Although, as always, none of this is intended to be acted upon medical advice. This is all conceptual, all educational. Please do your own research. Refer to your own hospital's guidelines. Wonderful. Let's continue. Adverse effects, how to monitor it, how to titrate it, and then we'll end with some practice questions. So no further ado, let's dive into Dexmedetomidine. So what is Dexmedetomidine and what isn't? So Dexmedetomidine, often referred to as Dex, D-E-X, is an intravenous sedative medication. If I could borrow a quick 60 seconds of your time, I wanted to introduce you to a community we're really excited about building, and that is our Patreon community. In this community, you will get access to high-yield medical education posts, ad-free videos, study guides, practice questions, mini courses, book chapters, and much more. You will see that by joining this community, you will get access to the PDFs, the study guides for every single YouTube video. Here's an example of one of those right now. In addition to that, you will get access to mini courses. In these courses, we will have videos, study guides, practice questions, bedside tips and tricks, and 30 practice questions at the end to test your knowledge. In addition to that, we have collections on every major emergency critical care topic that contains videos, medical education posts, practice questions, study guides, all categorized. And lastly, we have book chapters. These book chapters are high-yield clinical reviews, such as this one on the basics of mechanical ventilation. Beyond that, we have ad-free videos, we have practice questions, and we are constantly innovating and integrating new resources for you all. If you have a passion for emergency critical care medicine like us, consider joining this community today. In it, we hope that you will find all the resources necessary to push your knowledge to the next level and really improve the bedside care of these critically ill patients. People often refer to it as compared to some of the other sedatives like propofol and midazolam, although we don't tend to use much midazolam. When they compare it to those two, they kind of say, it creates a more arousable and cooperative sedation state. And this is mostly true, although not perfectly true, but patients tend to be more quote-unquote awake than patients who are on propofol, and certainly than those on midazolam. It helps with anxiety, agitation, ventilator tolerance, although we're going to cross that out because we feel passionately that ventilator desynchrony should be addressed on the ventilator until you're out of options, in which case sedation is not unreasonable. And one of the really nice things about Dexmedetomidine is it causes minimal respiratory depression. So when we're trying to lighten sedation, or we're trying to assess readiness, or we have to keep someone on some low dose sedation, even when we want to extubate them, you can extubate intubate patients on dexmedetomidine who meet criteria because it has very minimal respiratory depression. That's in comparison to something like propofol or midazolam, which have lots of respiratory depression. Although I guess can't speak for everybody, but it would be atypical and very high risk to extubate anybody on a propofol infusion. It is not a primary analgesic. We want to point that out, right? This is not a medication that's used primarily to treat pain. And in mechanically ventilated patients, we often have what we call an analgesia-first strategy, which means that we should treat patients' pain first, rather than just try to sedate the pain away from them. So analgesia first, and dexmedetomidine is not a primary analgesic. Just as a shout out, we have a whole bunch of episodes on sedation and pain control and all that in the mechanically ventilated. One of the pain scores people use is called the CPOT score. So if you have an interest in learning more about that, just search whiteboard medicine CPOT, CPOT, and it'll pop up. But yes, now with that being said, dexmedetomidine does have some pain control properties, okay? So you're getting a little bit of analgesia while using dexmedetomidine, although that's not its primary property. If you are targeting deep sedation, goodness forbid someone is so sick and they're being paralyzed for whatever reason, and you need to put them in deep sedation to then give them neuromuscular blockade, dexmedetomidine is not ideal as the only agent. It doesn't often reach deep enough sedation levels to be the only agent. So you most likely will need an additional or alternate agent. But for those who you're targeting light sedation, right, those that you're, trying to get more awake or get off the ventilator, dexmedetomidine is a really nice drug. Mechanism of action, how does it work? So dexmedetomidine is a selective alpha-2 adrenergic agonist. That is a mouthful. So it is a selective alpha-2 is the receptor, adrenergic because they're catecholaminergic receptors, and agonist means it stimulates it. So what does that mean? It really decreases sympathetic outflow, right? Sympatholysis, lyses the sympath, decreases sympathetic outflow. That makes patients calmer, lower catecholamine tone. It resembles kind of like a sleepy-ish state. They can often awake and follow commands, all that kind of stuff. So like from a summary standpoint, dexmedetomidine mechanistically is an alpha-2 agonist that works centrally, and it causes sympatholysis or decreased sympathetic outflow, which leads to this kind of arousable state of sedation. When is it especially useful on the vent? Well, Dex really shines when your sedation goal is that light sedation, right? That RASS of 0 to -1. If RASS is a foreign concept to you, the Richmond Agitation-Sedation score, again, search whiteboard medicine RASS. We got some episodes on it. But when you're really targeting that light sedation, you want better participation in a neuro exam. You don't want a patient snowed at all. Maybe you're transitioning them to spontaneous breathing trial to get them ready to extubate, all that kind of stuff. Dexmedetomidine is a really nice drug in these instances, probably one of the better ones. How do we dose it? Titration, practical bedside strategy. We would be remiss if we just didn't say one more time, this is all educational and conceptual. None of this is intended to be acted upon directly as medical advice. All right, typical ICU infusion dosing. In the intubated patient in the ICU, we typically do a maintenance infusion, and the dosing here is often around 0.2 to 0.7 micrograms per kilogram per hour, okay? So this is a weight-based dose, micrograms per kilogram per hour. And this is going to be titrated to your sedation level. Okay, you're saying, what's my RASS goal? My RASS goal is 0 to -1. I'm going to titrate my dexmedetomidine infusion to get to that level. What dose to initiate it at is highly variable. Some people start at 0.2, some at 0.4. Institutions have different protocols related to this, but it's not uncommon for it to get dosed up to 1 microgram per kilogram per hour in the ICU. Okay, that would be higher doses of dexmedetomidine, but not like, crazy, wild, what are we doing type of doses. In the world in general, you can give a loading dose of dexmedetomidine. Now, this is not commonly done in the ICU, at least in our anecdotal experience. But if you look at the drug itself, loading dose is not something that is unreasonable in some contexts. Now, the loading dose can cause worsening bradycardia and hypotension. I think that's probably a reason most of us don't tend to do it. And why do it? But it is something possible, just more as an informative little side comment. Titration approach So after you start it at whatever dose you choose, maybe you're starting at something like 0.2, 0.3 micrograms per kilogram per hour. Most people will titrate it by 0.1 to 0.2 micrograms per kilogram per hour. Every 15 to 30 minutes is a common kind of titration duration, right? Because you want it to reach its steady state, its threshold, before you then make a dose change. Okay, and again, most titrated to a RASS score of -1 to -0. -0 doesn't exist. Okay, so starting dose 0.2 to 0.3 micrograms per kilogram per hour, titrate by 0.1 to 0.2 micrograms per kilogram per hour every 15 to 30 minutes to reach your desired RASS goal. Again, if you are trying to target deep sedation, dexmedetomidine is probably not your best hammer. Propofol would be a more achievable agent there. Dose reductions, just note that those elderly greater than 65 years old and those with liver impairment sometimes need a little bit of a dose reduction, but you're titrating it to effect anyways. So just, FYI of note. What to monitor for when your patient is on dexmedetomidine. The big watchouts here are bradycardia. This is probably the number 1, 2, and 3 thing to watch out for. Dexmedetomidine is classic for causing bradycardia, and it's sometimes significant, right? Sometimes these heart rates can way drop, and in a patient who's maybe in shock or sick, dropping their heart rate can be a really big negative thing. What is our cardiac output? Our cardiac output equals stroke volume times heart rate. So if my dexmedetomidine is decreasing my heart rate and my stroke volume can't go up because I'm critically ill, that means dexmedetomidine is decreasing my cardiac output. So you got to be really vigilant for this. And if it's happening, you have to then decide, is this causing hemodynamic issues or not? And even a better way to describe it would probably be, is this causing perfusion issues or not? It can cause maybe some degree of hypotension. That's less common in its purest form. Obviously, causing bradycardia can cause hypotension, but causing hypotension without bradycardia is less common, although can happen. If you do load, sometimes there's this reflexive initial hypertension that occurs. I feel like anecdotally you don't see this happen that often, but you will read about it. And then obviously you're monitoring your sedation targets with your RASS score, like we've talked about. All right, adverse effects, the must-know list, just to dive into it more. We already talked about bradycardia. This is the most characteristic adverse effect of dexmedetomidine. You're higher risk if a patient has baseline bradycardia, any conduction disease at baseline, high vagal tone, on AV nodal blockers, or if you give a loading dose, right? Some would suggest that in these patients, maybe you should avoid dexmedetomidine. Think about a different agent just because you're very high risk for bradycardia. Another one we talked about, adverse effects are hypotension. You get decreased sympathetic tone. How do you vasoconstrict your peripheral blood vessels? You do so using sympathetic tone. So if you're decreasing sympathetic tone, you can cause some degree of vasodilation, hypotension, especially if you're hypovolemic to start, right? If someone's normotensive, you put them on dexmedetomidine, they become hypotensive. Something to think about is, are they actually hypovolemic? Did you unmask the hypovolemia? Another thing to note, which we'd mentioned, was hypertension initially with a loading dose. This is not very common, but peripheral alpha-2 effects can cause transient hypertension if you're giving a rapid load. And then the fourth thing to note is withdrawal after prolonged use. This is definitely a real thing. If someone's been on a prolonged infusion of dexmedetomidine, you abruptly discontinue it. It may cause a withdrawal pathydrome, which often looks like agitation, tachycardia, and hypertension in some patients. Clonidine is an oral medication. It also comes in patch form that is also an alpha-2 agonist. And if someone has been on a prolonged infusion of dexmedetomidine, some folks will do a clonidine taper, right? So the dexmedetomidine comes off and then they use clonidine in taper dosing over a couple of days to then prevent or treat that withdrawal pathydrome. Contraindications and major precautions. This is mostly related around the heart rate issue, right? So extreme caution if a patient has baseline bradycardia or any AV block, okay? Profound hemodynamic stability is not an absolute contraindication, but you just got to be cognizant because you're going to drop that heart rate. I should say potentially drop that heart rate, which can decrease cardiac output. And then if you need deep sedation, that's kind of a relative contraindication here because dexmedetomidine will not achieve that alone. Research guidelines related to dexmedetomidine use in the mechanically ventilated patient. The 2018 SCCM guidelines, suggest using propofol or dexmedetomidine over benzodiazepines, so avoid benzodiazepines in the mechanically ventilated sedated patient. There was a focus update in 2025 that maybe suggested dexmedetomidine actually over propofol when you're targeting light sedation, that RASS of 0 to -1. Or delirium reduction, because dexmedetomidine does have some research on delirium reduction, which we should have included in this episode. We didn't. If that's some interest to folks, let us know. We could put out a little kind of short update about dexmedetomidine and the data on delirium reduction. All right, head-to-head trials between propofol and dexmedetomidine. There was a major trial, the MENS 2 trial. There was not a meaningful difference between dex and prop in days alive without delirium or coma, ventilator-free days, or 90-day mortality. Great trial. Well done. We enjoy it. Okay, practical takeaway. Dexmedetomidine is an excellent drug for maintaining light sedation, facilitating ventilator weaning. Not necessarily better than propofol from a hard outcome standpoint, but there's maybe some suggestion that dexmedetomidine in those where you're really focusing on light sedation, getting off the ventilator, or preventing delirium, maybe some suggestion that dexmedetomidine might be a little better than propofol, but that's extrapolated, not kind of evidentiary confirmation there. Okay, rough approach for an educational standpoint. Decide your sedation goal. If it's RASS is 0 to -1, treat pain first. We have an Analgesia-first strategy. You don't want to try to sedate the pain out of someone. If you treat pain first and you have not met your RASS of 0 to -1, consider using dexmedetomidine if you're able to. If they're not bradycardic, they don't have AV nodal blocking issues, maybe their hemodynamics will tolerate it well. Start at 0.2 to 0.3 micrograms per kilogram per hour. Titrate it slowly, Q15 to 30 minutes. If there's any bradycardia or hypotension, you really got to think about, are they hypovolemic? And should I be stopping the dex, especially for bradycardia? All right, that's all we have. Let's dive into some practice questions. For those of you that made it to the end of this episode, y'all are rock stars. Our practice questions, we have 3 of them, beginner, intermediate, and advanced in that order. We will read the question, read the 4 answer options, and then we will go right into the answer. So if you need more time to think about the answer, just pause the episode because we're just going to jump right into the answer. Question 1, dexmedetomidine produces sedation primarily through A, GABA A, B, mu opioid, C, alpha-2 adrenergic agonism, or D, NMDA antagonism. Pause if you need to. The correct answer is C, right? Dexmedetomidine is an alpha-2 adrenergic agonist. GABA A would be propofol. Mu would be something like morphine or other opiates. NMDA, ketamine is actually NMDA, so that's something good to note. But yes, dexmedetomidine or dex is alpha-2 adrenergic agonist. All right, question 2. Which adverse effect is most characteristic of dexmedetomidine in ICU sedation? A, severe respiratory depression, B, bradycardia, C, malignant hyperthermia, or D, propofol infusion syndrome. Hopefully you don't choose that last choice. Correct answer is B. Dexmedetomidine is a sympatholytic, right? It decreases sympathetic outflow. It is classic for causing B, bradycardia. It does not cause severe respiratory depression. You can extubate on dexmedetomidine. It does not cause malignant hyperthermia, and propofol causes propofol infusion syndrome rather than dexmedetomidine. We have episodes on propofol too, so just search Whiteboard Medicine propofol, and you can learn all about that one. Last question, question 3. A mechanically ventilated patient is being prepared for an SBT. You want light sedation, RASS of -1 to 0, with the ability to wake and follow commands, but the patient's heart rate is 48 with intermittent second-degree AV block. What is the best interpretation? A, dexmedetomidine is ideal because it supports hemodynamics. B, dexmedetomidine is relatively contraindicated due to bradycardia and conduction disease. C, dexmedetomidine provides strong analgesia so it can replace opiates. Or D, give a loading dose to rapidly reach steady state and reduce desynchrony. Correct answer is B, dexmedetomidine often worsens bradycardia and conduction abnormalities. In a patient with a heart rate of 48 and intermittent AV block, it is a highly risky choice. Consider alternate strategies. And dexmedetomidine does not support hemodynamics. It does not provide strong analgesia, although it does provide some analgesia. And giving a loading dose in a patient who's already bradycardic, that's even riskier than starting it in general. All right, welcome back to another episode here at Whiteboard Medicine. We appreciate you checking it out. Hope everybody's having a lovely day. We appreciate you hopping on and learning with us. Today we're going to be talking about a very common topic in emergency critical care medicine, and that is the use of fentanyl in the mechanically ventilated patient. We just got off a week of rounding in the medical intensive care unit, and certainly many patients on mechanical ventilation were receiving fentanyl. Luckily, we did not see anybody who developed wooden chest syndrome. If you're sitting there and saying, what's wooden chest syndrome? Well, stick around in the episode and we're going to find out. Let's dive in what fentanyl is and what it isn't. Fentanyl is a potent opiate analgesic, right? You can just give a dose of fentanyl, right? Like a bolus of fentanyl, a push of fentanyl. It is an opiate analgesic. In the emergency department, in the emergency room, or even in the ICU for acute pain, you can give someone a dose of fentanyl, right? EMS often is able to give patients doses of fentanyl. So this is a potent opioid analgesic. It's commonly used in intubated patients, though, to treat pain from their illness, procedures, what have you, being on a ventilator with an endotracheal tube and getting suctioning, even air hunger to some degree. But in the ICU intubated population, we often put patients on fentanyl infusions, which we'll talk more about. Whereas in the acute pain, whether it's the emergency department or pre-hospital world, you're usually giving patients a push of fentanyl. So that's a little bit different. Okay. Key point here is fentanyl is an analgesic, right? It treats pain. It might provide some sedation, but it is not a primary sedative hypnotic, like something like Propofol or even Dexmedetomidine. Fentanyl is primarily used for analgesia. And in critical care, we often talk about this analgesia-first strategy for patients on mechanical ventilation. We want to treat those patients' pain first. We have talked about on this channel before the CPOT score, CPOT, CPOT. If you don't know what that is and you want to know, just search Whiteboard Medicine CPOT, because this is a score we use to help us understand if patients are in pain on mechanical ventilation, because we don't want to just try to sedate the pain out of the patient, right? We want to treat it with an analgesic first. And a lot of our sedating medicines, Propofol for instance, does not have significant analgesic properties, whereas fentanyl does. So critical care mantra, analgesia first strategies, treat pain before escalating sedatives, and fentanyl is a great agent for that. What is the mechanism of action of fentanyl? Well, fentanyl is a mu opioid receptor agonist, okay? So it decreases the neurotransmitter release in pain pathways. It increases pain tolerance. It decreases pain perception. And as doing such, it also decreases respiratory drive and has some sympathetic blunting, which can be important, especially if we were to be talking about giving this to patients not on mechanical ventilation, which, we're not in this episode. So all this is patients on mechanical ventilation. When is fentanyl especially useful in our mechanically ventilated population? Well, it's a great choice for rapid onset intravenous analgesia. Again, you can give it in bolus or push form. You can also put patients on an infusion on a drip. It's easily titratable for ongoing pain, right? Whether it's from the endotracheal tube or chest tubes or traumas or burns or what have you. And it's nice as an initial analgesia first base layer while you ensure pain is well controlled. And if there's still issues, then you initiate a sedating medication like Propofol or Dexmedetomidine. Guidelines and ICU liberation resources emphasize that, right? They emphasize opiates, fentanyl in particular, as first-line pharmacotherapy for ICU pain, obviously using the lowest effective dose and protocols when possible, looking at that CPOT score. Dosing and titration. We'd be remiss if we did not emphasize, as we always do, that this episode is conceptual. It's for education. It is not as to be used directly as medical advice. Certainly read on your own. Certainly come up with your own dosing based on sources and hospital protocols and guidelines, so this is all conceptual and educational. Okay, common continuous infusion ranges from an educational standpoint. A commonly referenced ICU range for fentanyl is 0.5 to 5 micrograms per kilogram per hour. And certainly this is going to vary, by patient tolerance, their physiology, how much pain they have. You're going to have local protocols and things like that. But this is a good starting point. And if you really think about what this means, if we were to make someone 100 kilograms, right? So this would be 50 to 500 micrograms per hour for someone 100 kilograms, which is someone overweight, right? If we were to decrease that to 50 kilograms, it'd be 25 to 250 micrograms per hour. And I'll tell you, anecdotally, at some institutions, sometimes 150 can be a max, sometimes 300 can be a max, so it's very uncommon to get to something like 500. But in patients who you're targeting kind of deep sedation or in severe pain or have some opiate tolerance, you sometimes might be getting up there towards 250 or 300. Titration strategy, just kind of a foundational approach. First, pick a pain target, right? What are you titrating your fentanyl to? Commonly, we use that CPOT score. What is your CPOT goal? Start low, right? There's no reason in just starting this at huge doses, and titrate in small steps while reassessing frequently. And remember that CPOT is for pain, your RASS score is for sedation, and your CAM ICU is for delirium. And we have episodes on all these. If you search whiteboard medicine, search CPOT or RASS or CAM ICU. You can bolus fentanyl, as we talked about, right? And rapid IV boluses can be useful. You're going to be suctioning a patient or turning them or doing wound care. Giving them a bolus of fentanyl might help them be in less discomfort during those procedures. But if you're going to bolus fentanyl, just know there's increased risk of respiratory depression. Not very relevant when a patient is on a ventilator, unless that patient is on ventilator settings that allow them to control some of their minute ventilation. Let's say they're on pressure control or pressure support, right? And then it becomes relevant if you have transient respiratory depression. And bolusing fentanyl can increase the risk of something called wooden chest syndrome, which we're going to talk more about. Okay, so if we're talking about kind of the educational approach to dosing, and we take out the weight-based, right? Patients often get started on 25 to 50 micrograms per hour, right? You're going to be titrating this, often titrated in 25 microgram per hour aliquots, although it's going to be dependent on your institutional protocols. And if you're getting up towards 200 and certainly up towards 300 micrograms per hour, those are really substantial doses. But the thing to remember is this is supposed to be weight-based, right? In a perfect world, it's a weight-based dose. So if you have someone who is quite heavy, they have many kilograms, that 300 micrograms per hour is going to not be as robust, right? If you have someone who unfortunately only weighs 40 kilos, compared to someone who weighs 120 kilos, that 300 micrograms per hour for let's just make this easy, 150 kilos and someone who is 50 kilos, that 300 micrograms per hour for the 150 kilo patient is literally going to be 2 micrograms per kilogram per minute, which is not honestly that much based on weight-based dosing. Whereas for that 50 kilo person, that is going to be 6 micrograms per kilogram per minute, which is quite high. So remember, this is weight-based. The absolute dose is what we often look at, the micrograms per hour. But what that means is very different depending on the weight of the patient. Okay, monitoring clinical targets. We kind of already talked about this, right? Your clinical targets when you're monitoring fentanyl dosing is going to be your pain scores. CPOT's a big one. BPS is used in some patients as well. Total opiate exposure is important because these opiates, this fentanyl, we're targeting pain. So at times, some patients need sedation, and they're not in pain or their pain's well controlled, but sometimes we start cranking up the fentanyl for sedation rather than pain. And then we get this analgesia creep where we're deepening sedation by increasing the fentanyl, and we get to these huge doses where in reality we should have titrated the fentanyl to treat their pain and then introduced another agent like Propofol or like Dexmedetomidine to then sedate the patient. So be careful about analgesia creep, where we start deepening sedation using fentanyl, which is a little outside of what we typically will use the fentanyl for. Safety monitoring, again, if someone is on a mode of mechanical ventilation, position where they can control their own minute ventilation. We talked about pressure support and pressure control. You do have to think about if you're going to worsen your hypercapnia by causing some degree of respiratory depression with higher doses of fentanyl. Opiates can contribute to hypotension and bradycardia. It's not nearly as common than with things like Dex, which is classic for causing bradycardia, which we talked about in our Dex episode, or Prop, which is classic for causing hypotension. And the Dex can cause hypotension, although it's not as common, and the Propofol can cause bradycardia, although it's not as common. But fentanyl can cause hypotension, bradycardia, but it's not nearly as common. It's a fairly hemodynamically neutral drug. Now, as an opiate, bowel function is important. Right? Opiates slow down your bowel peristalsis. It can cause ileus, it can cause constipation, and a lot of our ICU patients sometimes struggle with these things to start with. So we have to be very cognizant of bowel function and our patients receiving fentanyl, especially larger doses of fentanyl. And then you will develop some tolerance over time. And if you're on a fentanyl infusion, if you have a patient on a fentanyl infusion for a prolonged period of time, there might be some opiate withdrawal pathogenic by DCing that fentanyl. So you always got to be thoughtful about that in our patients. Adverse effects. So as we talked about, respiratory depression and apnea are big things with any opiate, fentanyl included. In a ventilated patient who can control their own minute ventilation, think pressure control mode or pressure support mode. This can matter. If you have someone on volume control, and you have their respiratory rate at a reasonable number, it's kind of protecting their minute ventilation, so maybe less relevant, but still important to know and think about, okay? Hypotension and bradycardia. We talked about fentanyl is not as classic for causing hypotension and bradycardia, but it can, especially at high doses, especially in patients who are under resuscitated, and especially if there's co-administration with other sedatives. A bigger thing that we think about is ileus constipation and urinary retention, classic kind of opioid adverse effects, so that should be something you're very thoughtful about. And then a few rarer things, but things that are really important. One is delirium. We have patients all the time in the ICU who get delirious. And again, we got an episode on the CAM ICU, which is a way to evaluate for delirium in the ICU. Just search. We're a broken record. Gosh, we got to stop. Whiteboard medicine, CAM ICU. But opioids can contribute to delirium, but it's usually not the only cause of the delirium. Delirium is often multifactorial. Sedatives in general can sometimes contribute to it, although dexmedetomidine has some pretty decent literature on being a decent choice in a patient who's delirious. But nonetheless, we're going on a tangent. Opiates can contribute to delirium, so you just got to be cognizant of that. And then the biggest thing, and we have actually never seen this, is something called wooden chest syndrome. Okay, this is where the fentanyl causes chest wall rigidity. And what you will see is sudden difficulty ventilating because their chest can no longer expand because they have chest wall rigidity, rising peak pressures, poor compliance, desaturations, and this can be really serious, right? This is rare but very high stakes. So we have never seen it, but if you have someone who's getting fentanyl and all of a sudden your peak pressures go sky high, you're having difficulty ventilating them, it is something that should be on your differential, is this chest wall rigidity or wooden chest syndrome. Risk for it increases with rapid injections, large doses, prolonged exposure, and really, like, sometimes the solution is you have to neuromuscularly blockade these patients. So very rare. We've never seen it, but it is something well documented, and it is one of those things that I feel like people like to sneak into kind of test questions. One of those scenarios that you almost never see clinically, but that is like classic for fentanyl. So keep it in the back of your brain for those of you out there that have to take tests on this type of stuff. Okay, contraindications and major precautions. The only hard contraindication, which is always like stupid to even put on, but if you have a known hypersensitivity to fentanyl, right, that's going to be a contraindication, which makes sense. Caution, people talk about hemodynamic instability. I always found this somewhat, I don't know, not helpful, because, you know, Propofol can cause hemodynamic instability, Dexmedetomidine can cause hemodynamic instability, fentanyl can cause hemodynamic instability. You don't have a lot of pain medications or sedatives that don't, although we also have some episodes on ketamine. Holler, check it out. It can cause CNS depression. So if you have someone who's, you know, not awake and interactive. They're on high doses of fentanyl. Certainly should think about that. And then prolonged infusions can cause tolerance withdrawal and opioid-induced hyperalgesia, where if you even brush the skin, it can be really painful. So these are kind of just cautions, things to think about. But in general, fentanyl is very well tolerated. Again, the thing we think most about is often ileus, constipation, urinary retention in these patients, which is just kind of classic opioid stuff. Okay, evidence of what the research says, guidelines, best practices. The Society for Critical Care Medicine does emphasize opiate-based strategies for ICU pain, lowest effective dose, have some protocols, this Analgesia-first strategy. But just like you don't want to sedate away the pain, you don't want to just try to give fentanyl to such high doses that it becomes sedating when you're no longer treating pain. So rough bedside approaches for educational standpoint, set goals, decide what CPOT you're going to target, know the RASS. Start analgesia, right? Fentanyl infusion. Start at something like 25 or 50 micrograms per hour, depending on the size of your patient. Titrate to pain, not to movement, not to RASS, titrate to pain. That titration is often kind of 25 micrograms per hour is often what people titrate by. If agitation persists, reassess cause. Is it still pain, or is it delirium, metabolic issues, agitation? Add or adjust any sedatives that are treating your agitation, things like Propofol, things like Dexmedetomidine, and always rethink, right? Every patient should have a sedation vacation, a spontaneous breathing trial who qualifies. Can you transition enterally? Can you lighten it? How are we going to prevent withdrawal if they've been on this for quite some time? All right, that's all we have for you for fentanyl in a mechanically ventilated patient. We do have 3 practice questions down here as well. We had some of you reach out saying that you all enjoyed the practice questions because we had stopped doing it. So we are back in action now. Practice questions, there's 3 of them, beginner, intermediate, advanced. The way we do this is we read the question, read the answer options, and we go right into the answer. So if you need more time to think about it, just make sure you pause the episode because we're going to jump right into the answer. Question 1, fentanyl produces analgesia primarily through A, NMDA receptor antagonism, B, GABA A potentiation, C, mu opioid receptor agonism, or D, alpha-2 adrenergic agonism. Correct answer, pause if you need to, is C. Fentanyl is a mu opioid receptor agonist, right? Just like many opiates. NMDA receptors are involved in the pathway for ketamine. GABA A receptors are involved in the pathway for Propofol. And alpha-2 adrenergic receptors are involved in the pathway for Dexmedetomidine. All right, whereas fentanyl is a mu opioid receptor agonist. All right, question 2. Which of the following is commonly referenced fentanyl infusion range for analgesia in mechanically ventilated patients? A, 5 to 50 micrograms per kilogram per minute. B, 0.5 to 5 micrograms per kilogram per hour. C, 25 to 100 micrograms per kilogram per hour. Or D, 0.2 to 0.7 micrograms per kilogram per hour. The correct answer is B. ICU resources commonly cite 0.5 to 5 micrograms per kilogram per hour, just from an educational standpoint. 0.2 to 0.7, people talk about this with Dex. 5 to 50 micrograms per kilogram per hour, or 25 to 100 micrograms per kilogram per hour are far too high, right? Okay, question 3. An intubated patient receives a rapid fentanyl bolus and suddenly becomes difficult to ventilate. Rising peak airway pressures, worsening hypercapnia, breath sounds are equal, there's no pneumothorax. The most concerning fentanyl-related diagnosis is A, propofol infusion syndrome, B, wooden chest syndrome, C, serotonin syndrome, or D, malignant hyperthermia. Correct answer is B, fentanyl-induced chest wall rigidity, also known as wooden chest syndrome. As we mentioned, we see this come up in test questions, and here we are. It can present with abrupt ventilatory failure, high peak pressures, poor compliance, especially after rapid administration, and in this test question, they received a rapid fentanyl bolus. All right, everybody, welcome back to another episode here at Whiteboard Medicine. We appreciate you checking it out. Today's episode is all about ketamine, and not just any ketamine, but the ketamine in the mechanically ventilated patient. This is a really nice drug in certain situations. That came out wrong. In certain situations, the mechanically ventilated patient, and it's one that's kind of newer to to the game when it comes to patients on mechanical ventilation. So by the end of this episode, we hope you understand what ketamine is, its use in the mechanically ventilated patients, adverse effects, things to watch out for, dosing approaches, all that kind of stuff. We do always have to say this is not intended to be acted upon as medical advice. This is educational and conceptual. Please reference formal guidelines in your institutional protocols and policies. No further ado, ketamine. What is ketamine and what isn't it? Or what it isn't. Either way, that's worded poorly. Apologies. Ketamine is a dissociative anesthetic. Okay? It can be used in ventilated patients, although there are multiple other indications for it. But in the ventilated patients, a lot of us think of it as an adjunct to opiate sparing, an adjunct to sedation, especially when hemodynamics limit the use of other agents, and maybe a more optimal or useful option in patients with bronchospasm, opioid tolerance, or are hemodynamically tenuous. Now, there's lots of caveats to this type of stuff too, and we're going to get into those as this episode progresses. But the key point here is ketamine can provide analgesia and sedation, right? It does both, and that's not as common for many agents, right? Propofol, which we've talked about on the channel, just search whiteboard medicine Propofol, is a sedative. It's a sedative hypnotic. Fentanyl, we've talked about that too, search whiteboard medicine fentanyl, is an opiate. It addresses pain, not necessarily sedation. Dexmedetomidine is an alpha-2 agonist, is primarily a sedative. Now there is maybe some contribution to analgesia as well, but it's primarily a sedative. Whereas ketamine does have analgesic and sedation properties. Best thought of as a bridge or booster agent. It's not as common to use it as the only sedative, at least not for every patient. How does ketamine work? What is its mechanism of action? Well, it's got a couple different pathways it works on. The headline, kind of the main mechanism, is it is a non-competitive NMDA receptor antagonist. And this causes analgesia or pain control, disassociation, and also anti-hyperalgesic effects. In addition to this, though, ketamine does have some activity on opiate receptors, and it has some sympathomimetic effects, increasing heart rate, increasing blood pressure via catecholamine release and reuptake effects. We just want to say that again. So its primary mechanism is as an NMDA receptor antagonism causing analgesia and disassociation, but it also has some activity at opiate receptors and some sympathomimetic effects, increasing catecholamine release. Now, one thing to note with this, and this is getting into the weeds a little bit, is there's a patient kind of who is catecholamine deplete. They've run out of a lot of their endogenous catecholamines. And in this patient in particular, ketamine may actually lead to worse hemodynamics rather than better when it's being used. This is a more advanced topic. Maybe we'll come out with an episode on that specifically. We're not going to dive into it for this kind of foundational introductory discussion, but just know that that is a thing and that does exist and people talk about it. Okay, ketamine is especially useful on the vent in certain situations. Some of those situations that kind of make clinical sense include the patient who is very opiate tolerant or has very difficult to control pain, right? Maybe burn patients, polytrauma, chronic opiate users, because this allows us to address pain through a parallel mechanism beyond just what the opiate they are on is giving them. It might also make sense in the hemodynamically fragile patient, right? If propofol is tanking their blood pressure and dexmedetomidine is causing severe bradycardia, maybe ketamine in that patient population would make sense. Patients with severe bronchospasm who need sedation, like an asthmatic, that goodness forbid you had to put on mechanical ventilation, because ketamine does cause bronchodilation, it might be a really nice drug for that patient. And then if you want some opiate-sparing analgesia, reduce the total opiate burden, it can be helpful for them. Let's see, I'm trying to think of the last clinical scenario where we may have used ketamine. There was a case where we had a really sick hypertriglyceridemia-induced pancreatitic with some kind of bradycardia issues that we were having trouble getting comfortable on fentanyl alone, and we couldn't use propofol because their triglycerides were already high. We wanted to stay away from Dex because they're already Brady. and the fentanyl alone wasn't doing it, so we added ketamine, and it went pretty well in that patient. So again, there's some unique clinical scenarios where maybe it makes a lot of sense. Dosing and titration, we're just saying it again, this is all educational, conceptual. This is not intended to be acted upon specifically, and please look at guidelines and your institutional suggestions for dosing. So ketamine dosing varies a lot across studies. A 2023 review talked about continuous infusions of ketamine in the ICU, found wide ranges. Some were using less than 1 milligram per kilogram per hour, some even less than 0.5 milligrams per kilogram per hour. But put it into context, we're going to talk about a few different ways ketamine is dosed. The first is pain-dosed ketamine. This is just as an analgesic, and it might be a nice starting point. And this is 0.1 to 0.3 milligrams per kilogram per hour. So your 100 kilogram individual, right? This would be 10 to 30 milligrams per hour of ketamine, unless we did our math wrong. No, that seems like good math. Okay. And then this is often titrated based on CPOT scores. If you're not familiar with that CPOT, CPOT, we have an episode on it. It's a way to objectively calculate possible pain using a number, a score that you can repeat over time. Just search whiteboard medicine CPOT and it'll pop up. So that's pain dosed ketamine. Sedation dosed ketamine, the dose is often commonly thought to be a little bit higher, right? Maybe 0.5 to 1 milligrams per kilogram per hour. Sometimes even higher than that, 1 to 2 milligrams per kilogram per hour. Some rates are even reported to be higher, 3 milligrams per kilogram per hour. The summary here, the thing to put in your head though, is that for pain dose, you're really going to be less than 1 milligram per kilogram per hour. So if you're just starting a ketamine infusion on someone on mechanical ventilation for an analgesic adjunct, you should be kind of at this less than 1 milligram per kilogram per hour, probably even less. Actually, it'd probably be better to say less than 0.5 milligrams per kilogram per hour for an analgesic adjunct. If you're trying to use ketamine as a sedative, your doses are going to be higher, right? Probably somewhere between 1 and 3 milligrams per kilogram per hour, just from an educational standpoint. Bolus dosing, you can bolus ketamine. It does increase the risk of hypertension, tachycardia, some of the psychomimetic effects that we'll talk about. And if you do bolus it, just do it deliberately, right? Be thoughtful about it. But you can bolus it to kind of try to get to whatever your desired effect is. So titration concept, just keeping it simple. Decide what you're going to target. Are you giving it for pain, in which case target that CPOT score and keep doses probably less than 0.5 milligrams per kilogram? Or are you targeting sedation, which is that RASS score, and your doses are going to be somewhere like 1 to 3 milligrams per kilogram per hour? Start low though. You can always give more. Elderly folks, those delirium prone, and those with, cardiovascular pathology are a little more at risk of some of the adverse effects that we'll talk about. Up titrate slowly in small steps every 15 to 30 minutes and reassess frequently. Trend scores. Don't just set it and forget it. All right, monitoring. What kinds of things should we be monitoring? Well, I already talked about this. If you're using it for sedation, you got to monitor the RASS score. If you're unaware of what the RASS score is, Richmond Agitation-Sedation score, we have a whole episode on it. Again, broken record over here, but just search whiteboard medicine RASS. Same thing with CPOT. If you're titrating this for pain, you have to trend your CPOT scores. In addition to that, you want to watch the heart rate and blood pressure. The sympathomimetic effects usually cause increased heart rate and increased blood pressure, but remember, in that catecholamine depleted patient, sometimes you can actually get paradoxical hypotension. Secretions, this is a big one. This is definitely one to note. Ketamine can cause hypersalivation, so you will often see increased secretions, and then it can cause delirium, just like many of these agents. So just note, ketamine sometimes will look like agitation when you first start it. You can get nystagmus, dissociation, odd movements, but make sure you're thinking about kind of the right behavior through the right lens. Adverse effects, as we talked about, it often causes hypertension and tachycardia, and not to belabor a point, but this is important. In that catecholamine deplete state, it can sometimes be a myocardial depressant and decrease the blood pressure, but this is, again, less common, but it does happen. Another adverse effect is psychomimetic effects. Ketamine is a drug that can be abused. It can cause dysphoria, hallucinations. You can get emergent reactions, so when a patient comes off of the ketamine, sometimes they can have really robust kind of violent emergence reactions. Now, if you have them on another sedative like Propofol or Dexmedetomidine, this often blunts these psychomimetic effects, but they do happen. We talked about hypersalivation. This is definitely a real thing. It will worsen secretion burden. And then there's a couple other things people talk about. One of those is increased intracranial and intraocular pressures. This is still traditionally taught. Choose your own destiny with whether you believe it or not. More recent data suggests that it maybe is not true and that it probably is safe in these patients, but this is still something that's commonly taught and thought about, so you'll have to decide kind of your belief system on that. Other toxicity themes, nausea and vomiting. It can cause some nausea and vomiting. This is not super common, but can happen. Okay. Contraindications and major cautions. So absolute contraindications, we always feel weird putting this on here, but if you have a hypersensitivity reaction to ketamine, you certainly shouldn't be using ketamine. Other things to think about: if you have severely uncontrolled hypertension in a patient, maybe they're hypertensive, emergency, or have some severe cardiovascular disease or major cardiovascular events, you want to be really cautious with ketamine. That might be a patient where you should consider an alternative. Aortic dissection, certainly, right? You're trying to control that shear force, that impulse control, aka bring the heart rate down, bring the blood pressure down. Starting ketamine and risking that sympathomimetic effect of increased heart rate and increased blood pressure is probably not the right thing. Active psychosis should be avoided, right? We talked about the psychomimetic effects that can happen. And then markedly elevated ICP. Again, whether this is really true or just kind of an old adage is unclear, but many institutions avoid giving ketamine, some with markedly elevated ICP. Ketamine is hemodynamically friendly until it isn't, right? So in the ICU, especially the medical ICU, we often have patients who are hypotensive and in shock. But some ICUs have patients who are hypertensive and have cardiovascular catastrophes like aortic dissection and all that kind of stuff. So ketamine might not be hemodynamically friendly for those patients. Cool. What does the research say on ketamine? This is something that's newer to the mechanically ventilated patient. There's been some trials out there. There was a 2021 pilot study that looked at adjunct ketamine and just focused on feasibility. There is some evidence on delirium and opiate-sparing outcomes, although it seems mixed. Low-dose ketamine reduced delirium but did not reduce opiate consumption. Dosing, as we talked about, is variable in the literature, ranging from less than 0.5 to less than 1 to less than 2, and some to less than 3 milligrams per kilogram per hour. So that's something that people are still working on teasing out. So ketamine in the mechanically ventilated, it is promising adjunct, right? It does have opiate sparing, sedative sparing. There's unique physiology. It's nice to be able to address things from kind of a separate, distinct adverse effect profile, and it probably will start to expand its use case. The one thing to note is it's often a lot of volume when someone's on a ketamine infusion. So if you have someone who's very tenuous from a volume standpoint, maybe you want to avoid ketamine as well. We should actually listed that up there. We didn't think to do that at the time, but yeah, it's often a lot of volume that the patient is getting. All right, we have 3 practice questions to end this episode. If you have not done practice questions with us before, there's a beginner, intermediate, and advanced question. We'll read the question stem, then go over the answer options, and then we'll go right into the answer. So if you need more time to think about the answer, just make sure to pause the episode because we're going to jump right into the answer. Question 1. Ketamine's primary mechanism for analgesia and sedation is A, GABA, A, B, alpha-2 adrenergic, C, NMDA, or D, dopamine receptor blockade. Correct answer, pause it if you need to, is C. Ketamine is best known for its non-competitive NMDA receptor antagonism, producing analgesia and dissociation. Remember, it does have some opiate effects too, some sympathomimetic effects too, but its primary is this NMDA. GABA-A is propofol, alpha-2 adrenergic agonism is Dexmedetomidine. For those of you that could think of all those, props to you. Question 2. A common pain dose ketamine infusion used as an opiate-sparing adjunct in ICU practice is closest to A, 0.01 milligrams per kilogram per hour, B, 0.1 to 0.3 milligrams per kilogram per hour, C, 5 milligrams per kilogram per hour, or D, 25 micrograms per kilogram per hour. Correct answer is B. Ooh, for a second I thought it said A. I was like, oh gosh. Correct answer is B. A commonly referenced analgesic ketamine infusion is 0.1 to 0.3 milligrams per kilogram per hour. And remember, for sedation, it's something more like 1 to 2, maybe even 3 milligrams per kilogram per hour, just from an educational conceptual standpoint, not as a recommendation. Question 3. Which patient is the least ideal candidate for ketamine infusion as an adjunct sedative due to physiologic risk? A. The ventilated asthmatic patient with bronchospasm. B. The trauma patient with opiate tolerance and hypotension on propofol. C. The patient with severe uncontrolled hypertension and a recent myocardial infarction. Or D. The patient needing opioid-sparing analgesia for rib fractures. Correct answer is C, right? Ketamine can C, patient with severe uncontrolled hypertension and recent myocardial infarction. Ketamine can increase heart rate and blood pressure. You should be very cautious in conditions when an increase in blood pressure would be hazardous, such as cardiovascular disease, poorly controlled hypertension, aortic catastrophes, all that kind of stuff. The other options here, an asthmatic with bronchospasm, ketamine is actually a really good choice because it can cause bronchodilation. Trauma patients with opiate tolerance and hypotension on propofol, great choice, right? Ketamine shouldn't worsen the hypotension, at least hopefully not. And it can help treat the pain from a different pathway than the opioids they're on. And then D, patient needing opioid-sparing analgesia for rib fractures. Again, that's another nice one because ketamine has that analgesic dosing. All right, everybody, welcome back to another episode here of Whiteboard Medicine. We appreciate you checking it out. Today, we are going to be comparing several medications used in mechanically ventilated patients for pain, for sedation, and it's going to be Propofol versus Dexmedetomidine versus Fentanyl versus Ketamine. We've actually come out with individual episodes on each one of these drugs, but this is going to be kind of a comparison, an overview of all four of them. Hopefully, it'll provide you with a better grasp on when to use each, what to monitor for, when to switch, dosing, all that kind of stuff. As we always say, this is not intended to be acted upon as medical advice. This is all for educational purposes for healthcare providers, as well as just kind of conceptual models. When it comes to dosing and all that kind of stuff, do not take these doses. Please make sure you look them up on your own and follow your institutional guidelines and protocols. All right, let's dive in. These four agents cover two core jobs in mechanically ventilated patients. The first is analgesia. Want to level up your medical knowledge faster? Join a community of like-minded individuals interested in emergency critical care medicine? Consider joining our YouTube members community. In this community, you will get early access to new videos before they go public, members-only videos including deeper dives, bonus content, study guides, and more, and members-only medical education, posts, updates, extra learning resources, and much more. If you're serious about mastering emergency critical care medicine or just want to join a community of like-minded individuals, this is the best way to learn with us every single week. If interested, hit that join button, and I hope to see you inside the community. And the second is sedation. And these are two distinctly different things, right? For analgesia, fentanyl is an analgesic. Propofol does not have analgesic properties. You should not be giving propofol to treat pain. Similarly, fentanyl does not have anxiolysis or hypnotic properties. You shouldn't be giving fentanyl to sedate. These are separate issues with separate medications. So the two core jobs, one is analgesia or pain control, two is sedation, which is anxiolysis and hypnosis. As we said, analgesia or pain control, fentanyl is our primary workhorse of these four medications. And then ketamine is a nice adjunct. There's an analgesic dose of ketamine that we'll get into for an educational standpoint, but fentanyl and ketamine are the two kind of analgesics in this group. Dexmedetomidine has some analgesic property, but not a ton. It's primarily a sedative. So when it comes to sedation, our sedatives are going to be propofol and dexmedetomidine. Ketamine also can be used as an adjunct sedative at certain doses, right? So ketamine can both be for analgesia or sedation, or both depending on the dose you're using. When it comes to kind of the ICU mantra, we tend to treat with analgesia first and sedation second, because what we don't want is to try to sedate someone's pain away. We want to make sure their pain is treated, and if they still require sedation thereafter, then we will provide them with sedation, but an analgesia first approach. So when we're talking about these four drugs, analgesia and sedation are two separate pathways case. Analgesics are fentanyl and analgesic dose ketamine. Sedation is propofol, dexmedetomidine, and sedation-dosed ketamine. Mechanisms of action, just one-liners. We went into more detail in the individual episodes. Propofol is a GABA-A potentiator, right? This is a hypnotic sedative. It's fast-acting. Dexmedetomidine is an alpha-2 agonist. It causes sympatholysis, or decreased sympathetic outflow. It's a nice kind of sedative to keep the patient arousable and cooperative. Fentanyl, like all opiates, mu-opioid receptor agonist. This is a potent analgesic. Again, maybe some sedating properties, but it's primarily for pain control. Ketamine is an NMDA receptor antagonist. It also does a couple other things within the opiate pathway and sympathomimetic, not to be confused with sympatholysis, and it is used for analgesia dissociation. It's often opiate sparing. So those are like the one-liners of these 4 medications, mechanisms of action, what each agent is maybe best for, or kind of practical use cases. Well, propofol is a fast-on, fast-off sedative. Okay, it's best when you need rapid control of agitation, easily titratable drugs, right, minute to minute. One of the common downsides, though, is it is well known to cause hypotension. All right, dexmedetomidine is kind of keep the patient calm but awake and awakeable. It's best if you really are looking to target that light sedation, that RASS is 0 to -1. If you're unfamiliar with RASS, just search Whiteboard Medicine RASS. We got a whole episode on the Richmond Agitation-Sedation score. And it's also a nice drug when someone needs a little sedation, but you still want them to participate in a neuro exam or wean from mechanical ventilation. You could even extubate patients on dexmedetomidine in the right clinical circumstances. But common downsides are going to be bradycardia is the main one. It also can cause hypotension, but bradycardia is the main one. Fentanyl is this analgesic base layer, right? It's a great workhorse for analgesia in the mechanically ventilated. It's best when you need pain control. Maybe it's a polytrauma patient, a burn patient. They're having a lot of discomfort with their endotracheal tube. They have procedures. It's a good analgesic first strategy to hopefully reduce the sedative needs later. Watch for any opioid side effects, right? Ileus, constipation, urinary retention, and then rarely but highly testable would be this chest wall rigidity, also called wooden chest syndrome, where your chest wall gets very rigid and your peak pressures on the vent go through the roof and you can't ventilate. We've actually never seen it, but it does theoretically happen. It's higher risk when you give kind of rapid boluses. All right, and then ketamine is a great adjunct for pain or sedation, especially when someone is hemodynamically fragile or they have a lot of opiate tolerance. So best used when you want to have opiate-sparing analgesia, an adjunct to sedation, especially if hemodynamics, hypotension is a limiting factor. And that can be really helpful in patients with bronchospasm like asthmatics because it causes bronchodilation. But make sure you watch out because it can cause tachycardia and hypertension. So if you have someone with aortic catastrophe or hypertensive emergency, probably not the best drug. It also will increase secretions, so be aware of that. And then it can cause psychomimetic effects. So if you have someone actively psychotic, layering on ketamine is probably not the best idea. All right, dosing and titration. Again, this is all conceptual. None of this is medical advice. So first and foremost, when you're titrating drugs, sedatives, and pain medications, make sure you're titrating them to a target. For pain, that's most often the CPOT score. For sedation, that's most often the RASS score, right? We have episodes on both these things. If you just search Whiteboard Medicine, either CPOT or RASS, what have you. When it comes to propofol, just roughly speaking, commonly people talk about 5 to 50 micrograms per kilogram per minute as a degree of range for propofol dosing. You can make quick adjustments. You can adjust it every 5 to 10 minutes because of how fast on and off it is. Dexmedetomidine, the dosing people often talk about are 0.2 to 0.7 micrograms per kilogram per hour, although you might see it as high as 1 or 1.2 micrograms per kilogram per hour. There is a loading dose that's possible, but this is often skipped because it can cause worsening bradycardia and hypotension. For fentanyl, common ICU ranges you'll see are 0.5 to 5 micrograms per kilogram per hour, and then titrating it based on CPOT scores or procedural needs. Many fentanyl protocols in the hospital also have an option to bolus the fentanyl from the bag in addition to the infusion rate they're getting. And then ketamine, wide dosing variability for mechanically ventilated patients. If you're targeting pain dose or analgesia analgesic dosed ketamine is often somewhere in the range of 0.1 to 0.3 milligrams per kilogram per hour. We sometimes think of it as less than 0.5 milligrams per kilogram per hour. So if you are putting a mechanically ventilated patient on ketamine just for its analgesic properties, this is where you want to stay, probably less than 0.5. Whereas if you were layering ketamine on for its sedation properties, you're really getting closer to 1 milligram per kilogram per hour. Sometimes this goes as high as 2. Sometimes it can go as high as 3, but there's not a lot. It's very institution dependent. Okay, adverse effects, some of the signature complications of these medications. So Propofol, we talked about hypotension. This is a signature issue with Propofol. In addition to that, hypertriglyceridemia. Propofol is a lipid... Whoa, excuse us. Is a lipid emulsion, so you will get hypertriglyceridemia in some patients. You should really be monitoring those triglycerides. Every institution is different. A lot of places do it Q48 hours. When people get concerned is different too. Just educationally, some people talk about when the triglycerides are more than 300. Some people talk about when they're more than 500. But just know you should be trending triglycerides and keeping an eye on it. Propofol-related infusion syndrome, or PRIS, is very rare. It does happen, but it's very rare. It's more common in high doses of propofol for prolonged periods of time. But when it does happen, it can be deadly. And it's profound metabolic acidosis, rhabdomyolysis, acute renal failure, acidemia, lactic acidosis, cardiac collapse. Some patients will trend CPKs. Not all places do, though. But just know, PRIS is something you should be actively keeping an eye on when you have patients on propofol. All right, signature adverse effects for dexmedetomidine. We talked about bradycardia. Bradycardia is the classic adverse effect. It can sometimes cause hypotension if you do load it, which we don't load it, but if you do, sometimes there can be this transient hypertension that can happen. And you should be really cautious with this drug in conduction disease or low heart rate states, because bradycardia is just such a classic adverse effect. All right, fentanyl. Classic adverse effects, respiratory drive suppression, which if someone is on a mode of mechanical ventilation that protects their minute ventilation, this isn't as big of a deal. But if someone is on a mode of mechanical ventilation where their minute ventilation might change based on their respiratory drive, such as pressure control or pressure support, then this can be meaningful. The thing we often think of the most about are things like ileus constipation, urinary retention, those common opiate side effects. So you really got to be watching bowel movements. If they don't have a fully catheter, you should be thinking about bladder scans if they start to produce less urine, all that kind of stuff, worsening abdominal distension, et cetera, et cetera. And then rarely but highly testable chest wall rigidity, known as wooden chest syndrome, associated with rapid large boluses of fentanyl. And then last, ketamine, classic adverse effects, tachycardia and hypertension, because you get sympathomimetic properties. Hypersalivation is very common. And then psychomimetic properties, hallucinations, all that kind of stuff, emergence reactions. We did just want to shout out, there's this entity, we're not going to go over it in detail, but in a patient who is catecholamine depleted, right? All of our bodies produce catecholamines, norepinephrine, epinephrine, all that good stuff. If we have a pathophysiology where our endogenous, our own catecholamines are depleted, sometimes giving ketamine actually can cause worsening hemodynamic compromise. Okay, so again, we're not going to go into detail. We might come up with a separate episode just on that, but just know it exists. It's a thing. So ketamine is not always the creme de la creme of medications to preserve hemodynamics. It can cause hemodynamic worsening in certain catecholamine deplete patients. Contraindications and when to avoid. So for propofol, profound hemodynamic instability is a patient where you want to be thoughtful because propofol will drop the blood pressure further. High dose prolonged infusions increase your risk of PRIS. Okay, so you want to be careful with that. Obviously, anyone who's hypersensitive, you should also not give them ketamine. And then there's this egg soy contraindication. You'll have to decide what you want to do with this. So in propofol formularies have, we think it's lecithin. Don't quote us on that, but this is also found in egg yolk. So, some would say that if you have an allergy to egg, you can't get propofol, but that's maybe true, but not necessarily true. Suppose if your allergy to eggs was that you were actually allergic to lecithin, then you shouldn't. And there's trials out there, and there's suggestions or recommendations. Just think about what your own institution does, and you can dive into literature and decide what you want to do too. But just know that this does exist as a possible kind of cross-allergy maneuver. Okay, dexmedetomidine, you do not want to use it if patient has significant bradycardia or any high-grade AV block. This is, again, so classic to cause bradycardia that you want to be very careful in that patient population. Fentanyl. If you're hypersensitive to fentanyl, if you get hypersensitivity reactions to it, you shouldn't use it. That makes sense. Also, if patients have like profound ileus or constipation or that type of stuff, you want to be careful. Rapid boluses that are high doses, remember you can get that chest wall rigidity, all stuff to keep in mind. And then ketamine, you want to be cautious or not use it. In patients where a sympathetic surge is dangerous, think about that hypertensive emergency or aortic catastrophe like aortic dissection. And then the other patient population are those with severe psychosis, because it can cause that psychomimetic reaction. All right, so kind of what agent to choose? How do we approach it? A simple choose the agent approach. Well, step one is, as we talked about, an analgesia-first approach. So the first thing you want to think about is to treat pain. You can do a CPOT score to see if it seems like they're in pain. If they are, consider starting fentanyl, right? That's a nice analgesic medication for those on mechanical ventilation who have elevated CPOT scores. Now, if they have opiate intolerance or escalating opiate needs, low-dose ketamine can be a nice adjunct for analgesia in certain patients. Step two, you've treated their pain. Maybe they still have an elevated RASS, right? So you're like, oh gosh, maybe I need to give them some sedation. What do I want to do? If I want something fast and quick to titrate, Propofol is a nice drug, right? If I want something that's just going to kind of keep them a nice light sedation, dexmedetomidine is a nice drug. If I have a patient where I don't think they're going to tolerate either of those, ketamine as an adjunct can be nice as well, sedation-dosed ketamine. And then reassess, see how the patient's doing. What's their CPOT? What's their RASS? How are they doing? Are they developing any side effects? Bradycardia, hypotension, hypertriglyceridemia, all that kind of stuff. All right, we tried to lay out, so if you're listening to the podcast version of this, we have a little table here, a comparison grid with agent, primary role, hemodynamics, respiratory effects, and kind of like best use case. This is in here just for review. All of our PDFs will end up get posted on our Patreon page under study guides, so that's where this will be if you want to take a look at it, or if you're watching this in video form and want to pause it, you can here, but we weren't going to go into the details. It's just kind of a table that summarizes the stuff we talked about. All right, end of the episode here. Brief overview of things. We do finish episodes with 3 practice questions. If you have not done practice questions with us before, the way we do it is there's 3 of them, beginner, intermediate, advanced. We will read the question, read the answer options, and then we'll dive right into the answer. So if you need more time to think about the question, please just pause the episode because we'll go right into the answer after we're done reading it. Question 1, which agent is primarily an analgesic, not a sedative hypnotic, and works via the mu opioid receptor? A, propofol, B, dexmedetomidine, C, fentanyl, or D, ketamine. Pause if you need to. The correct answer is C, fentanyl, right? So fentanyl is an analgesic. It does not have significant sedative or hypnotic properties, and it works by the mu opioid receptor. Receptor-wise, propofol, right, works by GABA. Dexmedetomidine is alpha-2, and ketamine is primarily NMDA. All right, so you kind of had 2 hints. Which one's just an analgesic and which one's an mu opioid receptor? All right, question 2. A ventilated patient is nearly ready for SBT, that's spontaneous breathing trial. You want light sedation with an arousable patient who can follow commands. What agent, best agent to emphasize for this patient? A, high-dose propofol. B. Dexmedetomidine. C. Fentanyl alone, titrated to a RASS of -4. Or D. Ketamine boluses every 5 minutes. Correct answer for this patient is B. Dexmedetomidine. Dexmedetomidine is great. It doesn't cause a lot of respiratory depression, so you actually can extubate on it in the right clinical scenario. You often get a light cooperative sedative state, whereas high-dose propofol, patients are going to often be deeply sedated. A RASS -4 is deep sedation, and using fentanyl alone to do that is quite dangerous, so that answer in general is just wrong. And then ketamine boluses every 5 minutes, why would you even do that? That doesn't make sense. Okay, question 3, the last question. Immediately after a rapid fentanyl bolus, an intubated patient becomes suddenly difficult to ventilate. Sharply increased peak pressures. Breath sounds, though, remain equal. There's no pneumothorax. What is the most likely explanation? A. Propofol infusion syndrome. B. Opioid-induced chest wall rigidity. C. Delirium. Or D. Ketamine emergence. Correct answer here is B. Opioid-induced chest wall rigidity, right? That wooden chest syndrome. Okay, again, we have not seen it, but it is something that's commonly tested, and it's most often in a scenario where you bolus rapidly high doses. Propofol infusion syndrome is obviously for patients on propofol, and that's rhabdo, acute renal failure, lactic acidosis, acidemia, cardiovascular collapse. Delirium can happen from any of these patients, but it wouldn't explain why the patient is having high peak pressures. And then ketamine emergence, wouldn't fit perfectly in this patient, because why would it happen if they got a fentanyl bolus? All right, that's all we have for you today. Let us know what thoughts, comments, questions you have down below. If you're interested in doing a deeper dive on any of these, we have episodes on fentanyl and dexmedetomidine and propofol and ketamine and RASS scores and CPOT scores and CAM ICU tools and all that jazz. Just search Whiteboard Medicine and then whatever it is you're looking for. We also will link things in the episode description as well as the pinned comment on YouTube. And then we're really active in our YouTube members community and Patreon community. We'd love for you to join those. Again, all that is linked in the episode description and the pinned comment on YouTube. Either way, though, stay well, keep learning, and we hope to see you all next time. Hey everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on.